Doctor, we are live now.
Good afternoon, everyone, for yet another exciting session of YOSI iROCK, the Resident Ophthalmic Combat of Knowledge. We have the Prelims Season 5 today, which is of the subspecialty cornea. Today, 9th of March, it's a Sunday afternoon, a glorious day, 2 to 4 p.m. We're going to have the contest, and we welcome all of you here. Today, I'm going to introduce you to this session through this video.
I think it's getting stuck a little. I don't think we can see the video properly.
Could you see everything? So Team YOSI welcomes you today, headed by a governing council, Dr. Divakant Mishra sir, past president Dr. Sonal Kalia ma'am, Karan Bhatia sir as the vice president, Dr. Nilesh as the secretary, Dr. Aditya Sethi and Dr. Prasanna V. Ramesh as the treasurer and joint secretary. Thank you so much for their support. Without this, the iROCK sessions could not have been conducted. So the YOSI team has executive members, as can be seen over here, and YOSI has multiple branches, and we try to help out residents and senior residents fellows in all parts of India through all of these avenues that we have. We encourage all the residents to kindly take note of these. The team YOSI iROCK consists of all of these members, and we are holding this contest to look for the best resident from India. Can you take over, Samita, because there's a lot of disturbance at my end?
Yeah, okay, sure. Should I share it from my side?
No, I'm sharing. You just basically,
okay.
yeah, just
Right,
I'll mute
okay.
myself so that there's a lot of.
Okay, sure. So let's begin this. So this YOSI iROCK was an initiative to find the best resident team in India. So we wanted all the teams across India to register, and it's a team of 3 people, and we will have 4 rounds. We will get to it. So we had 4 prelim sessions already. This is the 5th session, and the theme of today's session is cornea. And we will be so once the prelims are done, so we'll be telling you in subsequent what are all the things. And our last date was registration. We had kept as 25th December because we got amazing response from all the teams across the country. But now we are getting some queries that people want to participate again. So registrations are open again. So participants, if your friends or other people want to participate, do let them know. The last date is now 15th March. And we are open to further registrations, so we can have more prelims, and it'll be much more fun fighting out for the title of YOSI iROCK Superstars. And the final will be in YOSICon, which will be held in Delhi in September 5th to 7th. So, and registration for YOSICon is mandatory to appear in the final. So good luck to all of you. And yeah, so can we go next? Yeah. So each team will have 3 members, and members can be from different institutes or colleges. However, I think all of them are from same college here. And top 2 teams from each prelim will go to further rounds, and prizes will be awarded to top 2 teams of each round. We will announce the results after the conclusion. Give us some time. So maybe by today evening, we'll announce the results. We have 4 rounds: the iLeague, the seminar presentation, Pupils Got Talent, which is a creative round, which can be either a reel or it can be a video or anything. And the knowledge nexus is the quiz, and wordsmith war is the unscrambled words. So these are the 4 rounds. Your teams already got all the details before. We will be telling the rules of each round subsequently along with each round. There are audience questions and prizes to be won. So whoever else has logged in, please remain alert and do answer the questions. You have exciting prizes to be won for these audience questions. So with that, we will begin. And I would like to welcome all our judges, esteemed judges who are here on a Sunday afternoon to be part of this prelim session. So thank you so much. And
I'd like to
can we
introduce
continue?
Ritu Arora, ma'am. So,
Yeah.
ma'am has been the ex-dean of Maulana Azad Medical College and a professor of excellence at Guru Nanak Eye Center. She's the head of cornea and refractive surgery at Shroff Eye Center, New Delhi. She did her MBBS and her senior residency and her MD in ophthalmology from AIMS RP Center, and also has been awarded the WHO fellowship, which she did at Wills Eye Institute in the University of Toronto. She trained in DSEC and lamellar surgeries at the Dever Eye Institute in Portland. She has more than 150 index publications in peer-reviewed journals, 10 book chapters, and 350 plus presentations. She's been awarded the AO Achievement Award in 2010 and been a principal investigator in 12 national and international trials. She has keen interest in corneal surgeries, refractive surgeries, ocular surface, and infective keratitis. Thank you so much, ma'am, for sparing your time today for these young ones and for being here.
Thank you.
The
Thank you for
judge is.
I'm honored.
Thank you, ma'am.
Mhm.
The next judge is Dr. Swati Tomar. Ma'am has done her fellowship in cornea and anterior segment services from the prestigious L.B. Prasad Eye Institute at Hyderabad. She was a
Slide
faculty
need
at
to change, Arshi. Your slide need to change. Your slide is not changed.
Has my slide changed now?
No.
No.
It's only showing my CV. It's not. Yeah, now it's okay.
All right. Can you see ma'am's CV now?
Yes.
Yes, yeah, we can.
All right. So, ma'am has been a faculty at L.B. Prasad Eye Institute and now is the director and consultant at Swanetra Eye Hospital in Jaipur. She's also the honorary medical director of the Eye Bank Society of Rajasthan for the last 20 years and professor and unit head at NIMS Medical College in Jaipur. Can you please take over now? Again, I'll have some disturbance at my end, Samita.
Okay, sure. I'll just tell you if the slide is not moving so that you can just change it. So I welcome Dr. Swati ma'am. Thank you for joining us here for this prelim session.
Thank you, Samhita and Arshi.
Can I have the next slide, Arshi?
Can you see Dr. Sharad's slide?
Oh no, we can't.
I think there's a
It's
lag
still
on my
showing.
end.
Yeah, so
It's
shall I
going to
share
come.
it from my end? I'll just share it from my end. Can I do that?
Sure.
Yeah. Okay,
would
then
have
let me
put-
just share the PPT.
Yeah, stop sharing.
You stop sharing. I'll just. Sorry for this technical glitch. Just give us a minute. Yeah, let me just share it from my end. Yeah, so can you see the PPT now? It's not visible, I think. Is it visible now?
Yes, ma'am, it is visible.
Samita?
Visible now? Yeah. So I'll
So,
just.
Dr. Samita, we have the YOSI president, Dr. Devakant Mishra sir here, and he would give his opening remarks as well.
Hi,
Yes,
so
I think I'll just. Hi, sir. Welcome. So I'll just introduce the judges and then I would invite Dr. Devakant to give an address. Is that okay?
sure. Yeah, perfect,
Yes.
perfect. Take your time.
So our third judge for today is Dr. Sharad Gomse. Welcome, sir. So he's a senior consultant cornea, cataract and refractive surgery at Sri Ramakrishna Netralaya, Thane, Chembur and Vashi. He completed his MBBS from MGM Medical College and ophthalmology MS from AFMC Pune and cornea fellowship from the prestigious Shankar Netralaya, Chennai. And he has numerous publications in national and international journals and has given multiple presentations. He even received the gold medal for best video presentation in the annual conference of CSOS 2023. We welcome you, sir, for this session.
Thank you. Thank you, Doctor.
And our next judge is Dr. Rashmi Deshmukh. She is currently consultant at LV Prasad, Hyderabad in cornea, cataract and refractive services. She's trained at JIPMER and has done a fellowship in refractive surgery and cornea at Narayan Netralaya. She was a faculty for Center of Sight, and she's even done a fellowship under the mentorship of Professor Harminder Dua. And she's a senior clinical fellowship in cornea and cataract at the Cambridge University, keenly interested in academics and translational research with multiple manuscripts and book chapters and numerous honors and awards. I think we need a long time to read all her achievements. Ma'am, we are really lucky to have you here and welcome as a judge on this session.
Thank you.
So I now invite Dr. Divakant. He's our current president of YOSI, and I would like him to give an address and talk to all of us. Welcome, Dr. Divakant.
Thank you so much, and apologies for barging from, Arshi's account. So I just welcome all the judges for taking out their special time, Dr. Rashmi, Dr. Ritu Arora ma'am, and Dr. Sharad, Dr. Swati Tomar madam, and for the valuable time that they are going to give to this event. And to all the teams, and I think we have a very good representation from across India, almost from all the corners today. So best of luck to all the teams, and again, a big shout out to our organizing team for taking all the pains. So best of luck and look forward to a great show.
Thank you. Thank you, Dr. Divakant. I think the whole YOSI team has been working tirelessly for all these events, and Dr. Divakant has been ever encouraging, and we have a wonderful president. So we have been doing new initiatives, and hopefully we'll have a good session today. Thank you so much for coming in. So I'll introduce ourselves, the moderators for today's session. We have Dr. Arshi Singh. You all already met her. She's an assistant professor, glaucoma services at Guru Nanak Eye Center, Maulana Azad Medical College, Delhi. And she's done MBBS from AIMS, Delhi, and DNB from LV Prasad, and has done specialty training in glaucoma services at MAMC, New Delhi. She's also the assistant editor of Delhi Journal of Ophthalmology and section in charge of DOS Times and managing editor of YO Times as well. So welcome, Dr. Arshi. And we have Dr. Lipi, and she is a fellow in ASG Eye Hospital, an executive member of YOSI and team lead for the Cataract Focus Group. She's also the winner of annual YOSlides 2023, runner-up in YOSI Journal Club 2023, and she's won the Best Surgical Video Award in the Innovation category at ROSCON 24 and delivered various presentations at regional, state, and national conferences. She's featured in the AIOS Times and YO Times as well. Welcome, Dr. Lipi. And myself, Dr. Samhita, I'm a consultant in cataract, oculoplasty, pediatric, and squint at Netradama Super Speciality Eye Hospital. And I've done my fellowship in cataract from Shankara Eye Hospital and fellowship in oculoplasty training from Minto Eye Hospital and oculofacial aesthetics training under Dr. Kasturi ma'am at Shankardeva Netralaya, and senior residency and training in pediatric ophthalmology and strabismus also from Minto Hospital. And I would be one of the moderators. Thank you. So we quickly go, and I also would like to thank Dr. Nupur Goyal. She's the team lead on YOSI iROCK and the brain and the power behind all this prelim sessions and the whole YOSI iROCK we've been having. She could not join us today, unfortunately, but she's been constantly doing work, and without her guidance, I don't think we would have come up with this idea and executed it. So thank you, Dr. Nupur, and you'll be meeting her in the further sessions. So let me quickly introduce the participants and our teams. Shall I go ahead? Yeah, okay. So I'll quickly introduce the participants. So we have 5 teams today, and first team is the Eye Catchers, Team 1. They are from Kamdar Eye Hospital. We have Dr. Manisha Parmar, Dr. Purvi Gandhi, who is the captain, and Dr. Raj Siddharth. Are you all here, guys?
Yes, ma'am, we are here.
Okay.
Can we have
okay.
the
Welcome.
participants
Welcome.
log in as well and keep their videos on so that we can see your faces and the judges can meet you also?
Yes, please. Yeah. So they can see you and they'll know that you are the part of this team. So team 1 will be Eye Catchers. Team 2 will be Multifocal Warriors. They are from JLN Medical College, Ajmer. We have Dr. Simran Khosla, Dr. Ranu Sharma, who's the captain, and Dr. Madhur. Are you guys here?
Yes, ma'am.
Yes,
ma'am,
welcome,
we are all
Multifocal
here.
Warriors. Yes, okay, be ready. So our third team is the Eye Quizzards. They are from AIMS Raipur. We have Dr. Sanya Parak, Dr. Mustafa Magda, who is the captain, and Dr. Mohan Prasad. So welcome, guys. You're there.
We are all here.
Yes, okay, welcome. So the team 4 will be the asteroids. They're from iCare Eye Hospital and PG Institute, Noida. We have Dr. Prakriti Garg, Dr. Nisha Beniwal, and Dr. Kanchan Sharma. Are you all here?
Yes, ma'am, we are here.
Yes. Okay. So our 5th team will be Team Optic Nerds. They're from AIMS Nagpur. So we have Sanskriti Nahar, Dr. Lavina Paryani, and Dr. Samarpita Dhar, who is the captain. Hi guys, are you here? Optic Nerds? Yes, okay, okay. So welcome all teams. So be ready to battle it out and be part of the 2 top teams. And we have 4 rounds, as you know, and we can, of course, so without the GC support and guidance, this would not have been possible. So basically, let's get into the outline quickly. We have 4 rounds. Round 1 is the iLeague or the seminar. So you have all been given topics previously and you need to present the seminar. So present it from your end. And in case of any glitches, we are always here to help you out. And each person will present the seminar and we'll have discussion with our judges. And judges would be asking you some questions and you need to answer that. And we'll tell you the rules subsequently. Round 2 is awesome. Collaborate, create, and celebrate the road to awareness. So this is about reels or videos which you have already prepared. And you'll be presenting that, and we'll have the judges' comments on it. Round 3 will be the quiz, and 4 will be the unscramble, wordsmith war. So we'll start with round 1, the seminar. So Dr. Ashi, do you want to take over and we'll start this?
So the first team, kindly be ready. We'll just go over the rules once again. Can I have the next slide, Dr. Samhita?
Yes.
So there's be only one member from the team who will present. The presentation time is 5 minutes. Judges, please note, if they exceed the time limit, negative marks are to be allotted to them. Question and answer round has to be followed after the presentation, and that should be for 2 minutes. And total marks that you'll be awarded for your seminar presentation will be out of 20. And today's topic is from cornea. So for the first team, can start sharing the screen. Dr. Samhita, we can probably stop sharing.
Yes, please. So the first team, the eye catchers, can you please share your presentation?
Judges, please
stop
be
slide
ready with
share.
your
Yes.
mark sheets now.
Yes. So can you share it now?
And for our judges' information, ma'ams and sirs, basically, if there's a mentor present from the parent institute for the teams, they get an extra few points. And after their presentations, we've invited that the team captains invite their mentors to say a couple of words, and then we can proceed on to the question, if that's all right with you.
Yes. Yeah. Okay. So you can start sharing and presenting, Dr. Raj.
Yes, ma'am.
So this is the team eye catchers
Yes.
from Kamdar Eye Hospital. Yes, please proceed.
So, good afternoon to everyone and my fellow participants. Today we will be presenting regarding acanthamoeba keratitis. So I'll go through this topic in this order, from starting from introduction and proceeding to epidemiology, pathogenesis, clinical features, differential diagnosis, diagnostic methods, and treatments. So acanthamoeba keratitis is not able to.
I think you just switched off your presentation.
Sorry.
No problem. You can share it again. Are you able to? Yeah, we can see your presentation now. Yes. Continue.
Yeah. So acanthamoeba keratitis is basically a chronic form of keratitis, which is usually contact lens related, caused by free-living amoeba, namely the acanthamoeba species. Acanthamoeba is a parasite which is found ubiquitously in water and soil. It is during presentation, it is commonly mistaken for non-infectious type of keratitis, as well as some infectious forms of keratitis, which include bacterial, viral, or fungal. And the amoebic infection is known for its resistance to common antimicrobial agents which we use in our day-to-day ophthalmic practices. Excellent outcomes have been observed when the diagnosis is early and initiating the treatment before the deep infiltration starts. So coming to the epidemiology and pathogenesis, this acanthamoeba keratitis was first described in 1973 in USA. It is usually a rare form of infective keratitis, but usually occurs in periodic outbreaks. Cases like 1 in 21 to 25 cases have been noted. per 10,000 contact lens users. In India, it comprises of nearly 1% of all infectious keratitis. Acanthamoeba is a parasite which is found ubiquitously in water, soil, and air. And we have noted two forms, namely the active trophozoites and the dormant cyst form. We have nearly 15 to 20 genotypes, of which type 4 is the most common genotype. So coming to the risk factors, the major risk factor is contact lens wear. Mostly the patients wear soft contact lenses. Other risk factors include trauma, exposure to freshwater sources, swimming pools, hot tubs, homemade contact lens solution, and inadequate hygiene related to maintenance of contact lens. Acanthamoeba is also noted in regions of severe flooding where there's compromise in water supply. Regarding pathogenesis, we have two forms of acanthamoeba, namely the active trophozoites and the dormant double-walled cysts. Cysts are known for their resistance to extreme temperature, desiccation, that is the drying or irradiation, and antimicrobial and microbial agents, especially for chlorine. So the main species which is involved in this is Acanthamoeba castellani. The type 4 and type 3 genotypes are most common as discussed before. Primarily, the Acanthamoeba finds a way to attach to the corneal surface. This is by the mannose binding protein attaches to the mannosilated glycoprotein expressed in the epithelial surface of the cornea, and there they produce a matrix metalloproteinases, which starts degradation of the ocular surface. So the parasite can proliferate by subsisting on the bacterial prey or the resident keratocytes. So coming to the clinical features, it is usually, it ranges from asymptomatic to severe and disproportionate intractable pain. Actually, the characteristic finding in acanthamoeba is that the clinical findings and the symptoms don't correlate. That is, the patient has severe disproportionate intractable pain. Signs include epithelitis with perineal sparring, epithelial whorls and ridges as shown in these images, and that may be reduced sensation in spite of having a radial neuritis. When there is on further progression, there is antil-stromal invasion, which starts as shallow excavation and localized infiltration. So in these images, we can find in the first two images, we can find epithelial damage to the corneum. And here we say the radial keratoneuritis, and here there is stromal invasion, and there is deeper infiltration, and finally leading to a formation of an immune ring, characteristic immune ring with a central corneal haze and a surrounding opacity. So extracorneal manifestation can be limbitis, pleuritis, uveitis, or eyelid abnormalities and dacroadenitis. In severe cases, there may be development of hypopyon, anterior scleritis, and optic neuritis. So coming to diagnostic parts, it is usually based on clinical findings. Cysts can be seen through staining with the Gemsa stain, KOH, or calcofluor white, or acridine orange. The scrapings can be plated with E. coli, where they show characteristic snail tracks of gazing, and the transport medium is usually paste saline. And PCR and confocal microscopy are used for diagnosis. Here we can see central bright spot surrounded by a halo denoting the double wall cyst. So differential diagnosis may be bacterial, fungal, or other parasitic keratitis. The non-infectious parts include chronic epithelial defect, autoimmune disease, and rheumatoid arthritis. So treatment includes starting with topical medications like chlorhexidine and polyhexamethylene bicarbonate and propamidine and hexamidine. In severe cases, we can start with antifungals like ozoles, starting like voriconazole. In poor cases, in poor prognosis cases, surgical management includes wide mechanical debridement along with partial tarsorrhaphy or amniotic membrane grafting. Cryotherapy can be tried. Thank you.
Okay, so that's excellent. Thank you. And I think your mentor is here. Do you have, is your mentor logged in?
Yes, ma'am. Sir is here.
Dr. Rohan? Yeah, Dr. Rohan Agashi, please, can you please say a few words? Like, please introduce yourself and talk to us.
Hello, I am Dr. Rohan from Kamdar Eye Hospital, and I would like to take this opportunity to congratulate my team, first of all, Dr. Purvi, Manisha, and Dr. Artidar, and also a great initiative. Keep it up. Thank you.
Thank you so much, sir. So the team gets
Can we
plus
move on to the
5. No, Ashi, Dr. Ashi.
questions now? Yes, the data +5 for the mentor.
Yes. Yeah.
Ritu ma'am, any questions? Dr. Swati? Ma'am,
I'm
you
going
are
to
mute.
unmute.
Yeah.
Huh.
So it's a good initiative started by YOSI, and it is a good attempt, Raj, you made. But I wish you had stuck to the time and initiated your presentation in a proper manner. You've talked about the commonest presentation of the contact lens wearer risk factors. What is the risk factor seen in Indian? We reported from the Indian scenario. Because whatever you presented is the Western literature. What is the presentation of acanthamoeba keratitis from the Indian scenario? Because it is the non-contact lens wearers which have been reported as the higher incidence of acanthamoeba keratitis. Okay. And second, I wish you had used the pictures of the Indian patients. Because they were all light irises seen at the back. And as far as I know 5 minutes is too short a time for a seminar on such a detailed topic. And third, as far as the management is concerned, I don't think Vozol or voriconazole is the first line of treatment. Is the bioguanides, which needs to be corrected over there. Bioguanides are the first line of treatment with diamidines. But otherwise, it's been a good attempt. Thank you.
So nice presentation. I just have one question. Why do you think there is a lot of pain, disproportionate to the ulcer? Can you answer that? Why do you
Yes,
think
ma'am.
there is too much of pain in this?
The typical way the infection spreads is once it reaches the stroma, it has a typical preference to invade the corneal nerves, and it causes radial neuritis. Because of this, we have a intractable pain.
So what would be your first DD to this?
It can be usually viral keratitis like exhausted.
Do you think it does mimic sometimes as fungal also because of some features?
Dr. Rashmi ma'am, any questions?
Yeah,
Dr.
I
Shara.
had a comment actually, very similar to what Dr. Ritu ma'am was mentioning, that Vozols, I also would not agree in management. Bioguanide should have been the first go thing. And for sake of completion, even the surgical management, I don't think is entirely complete, because you've just mentioned mechanical debridement with AMG, but there is a role of transplant as well. So for completion's sake, I wish you had included that. When would you want to do? How would you want to do? At least the basic things is what I wanted to say. And another important thing is the recurrence in acanthamoeba keratitis is also very important. I felt that was a little untouched in the presentation, because the one thing we are worried about is incomplete eradication of the acanthamoeba infection, and then recurrence again.
I think he got only 5 minutes.
Yes.
That is the reason. It's difficult
Yeah,
to catch
yeah.
everything.
It was very
I
difficult.
will be okay with that.
Dr. Sharad sir, any comments or any questions?
No, I think they have covered most of the things, and I agree that 5 minutes is too short for the president to cover a seminar on a vast topic. But they manage well, so we'll move to the other topic.
Yes, sir. Okay. So I think we'll call the second team, Dr. Rashi, we'll call the multifocal warriors. Their topic was corneal dystrophy. So I ask one of you to please share your screen and start your presentation.
I once again request all of you to stick to time. It's very important that you don't get any negative markings.
Are you able to share your screen? Yes, yeah, we can see your screen. You can go to slide share, like presentation mode.
You're okay, don't worry. We haven't started time yet. Yeah,
Yeah,
put
we
it on the
haven't
full
started time.
screen.
I'll tell you when I start.
Ma'am, am I audible?
Yes, you're audible.
Yes.
Please go to presentation mode.
Okay, ma'am.
Slide share. Go to slide share mode.
Simran
Yes,
will
ma'am.
be starting your time now.
Good afternoon, everyone. Today I will be discussing about the corneal dystrophies. These are the non-inflammatory corneal opacifying disorders, usually inherited, bilateral symmetrical, with no relation to the systemic or environmental factors, gradually progressive. They begin early and centrally located. Let's
Slides are
start
not
with the
moving.
epithelial.
Slides are not moving.
Go to slideshow, please.
I've paused your time. Move to slideshow mode.
No, go down there. Press the slideshow. It is still in presenter view, no?
Ma'am, now moving.
It won't
No.
move.
Ma'am, are the slides moving?
No, it's not moving, and it's not in the slideshow as well. Like we can see your entire screen. I think you need to go to the slideshow. At the bottom, can you see that small one?
Ma'am, now the slides are moving.
We can't see you now. Your slide
You have,
share has
you have
got
to
switched
share
off.
your screen again. Your screen sharing has ended. I think we'll move to the third team. Team 2, you can get time to prepare. Third team, kindly start.
Third team, iQuizzards. Their topic is herpes zoster ophthalmicus. So one of you, can you share your slides, please? Share your screen. Yeah, iQuizzards, are you here? Please share your screen. Yeah, we can see it now. You can go to slideshow. So judges, please note, this is team 3, iQuizzards. And yeah, please continue. You can start. Okay, so your time starts now.
Good afternoon, everyone. Are my slides visible?
Yes, it's visible. Please continue.
So, this is from team iQuizzards. Our topic for today is herpes zoster ophthalmicus. So herpes zoster derives its name from the Greek words herpin means to spread or to creep, zoster means girdle or zone. So it's actually creeping around the node to the zone.
I think slides are not moving.
Supplies.
Yeah, slides are not moving and your
So
voice is breaking.
varicella zoster virus is a member of herpes virus family. It has
iQuizzards, your slides are not
produces two
moving.
diseases,
Please pause.
varicella, that is
Pause,
chickenpox,
1
and
minute.
it is
1
very
minute, doctor.
contagious form.
Can you hear me?
And the herpes zoster shingles is a reactive. So
We can chat with him. Hello, iQuizzards, your slides are not moving. And
moving
your
now.
audio is not clear.
Is it
No,
visible
it's
now?
not moving.
Hello?
It's not moving and your voice is also breaking. I think your internet connection is a little weak. Like we can't
You are
hear you very well.
you are still on
Now is it
first slide.
moving?
Yes.
Yes.
Now it's moved. Can you
Now?
move 2 more slides? Let's see whether it's working. Can you go to the next? Yeah, now it's moving. Yeah, please. Can you start?
Yes, ma'am.
I think we'll
Now it's
restart your
moving.
time.
Okay.
Yeah, okay. Yeah, we can restart your time. Can you please start now?
Yes. No, herpes zoster derives its name from Greek words. Herpin means to creep or to spread. Zoster means girdle or zone. So it is a creeping along the node to the zone it supplies. So varicella zoster virus is a member of herpes virus family. Produces two different diseases. Varicella, that is chickenpox, and it is a very contagious form. And herpes zoster, also called as shingles, and it is a reactivated form. So risk factors include a lifetime risk of herpes zoster is estimated to be 10% to 30%, and increasing age is a significant risk factor. And altered cell-mediated immunity like neoplastic diseases, diabetes, cardiovascular diseases, HIV, those who are on immunosuppressive drugs and organ transplant recipients, and females and whites have significant risk factors. So coming on clinical features, after primary infection, most probably during the childhood years, the virus remains latent in the sensory ganglions. So reactivation of this varicella zoster from sensory ganglia occurs. And the term herpes zoster ophthalmicus it describes the reactivation from the trigeminal ganglia. It usually presents as an unilateral painful vesicular rash with a dermatomal distribution. And the ophthalmic division is the most commonly involved, and 50% chances of ocular complications occur in case of nasociliary nerve involvement. So Hutchinson in 1965 described the vesicles at the tip of the nose indicates that involvement of nasociliary nerve, and it increases the likelihood of ocular involvement. So you can see in this picture the tip of the nose involved. Coming on to clinical features, it initially starts as a prodromal phase in the first week. It presents as fever, malaise, headache with burning, itching, and pain on the affected dermatome, mostly involving forehead, and it actually follows the midline in the dermatome supplied by the ophthalmic division of trigeminal nerve. And in after a week's period, there will be ocular manifestations, including eyelid, conjunctiva, episclera, sclera, cornea. Further progressing, and it also involves posterior chamber like acute retinal necrosis. So after years period, other complications like neurotropic keratopathy, orbital inflammation, cranial nerve palsy, optic neuritis also occurs. So some of the pictures here showing ocular manifestations. This is a typical picture of pseudodendritic keratitis in HZO, and this is staining with rose bengal, sclerokeratitis, and in case of prolonged manifestations like neurotropic keratopathy, corneal edema, and lipid keratopathy. And anterior uvea manifestations like uveitis, iris atrophy, and staphyloма. Neurological manifestations in herpes zoster, like post-herpetic neuralgia, is the most common. It is a pain persisting beyond 1 month after the rash onset. It can present as allodynia, deep aching pain, severe pain. So it is one of the leading causes of suicides in patients more than 70 years with chronic pain. Other complications, neurological manifestations are acute neuralgia, cranial neuropathies, encephalitis, and cerebral vasculitis. So how to diagnose? It is mostly clinical diagnosis with peculiar signs and symptoms, but when in doubt, the vesicular fluid and corneal scrapings can be subjected to Zank smear. We can see the typical inclusion multinucleated giant cells with inclusion bodies can be subjected to PCR and ELISA and culture, but culture growth is slow and it is virus is heat level. Serological tests, which includes IgM, where the fourfold rise in IgM titers suggestive of recent infection, and IgG, it assesses immunity or susceptibility in unvaccinated persons. How to manage? Supportive care in the form of artificial tears, cold compresses, and analgesics. Targeted therapy with antiviral agents started within 3 days, like acyclovir 800 mg 5 times per day for at least 1 week. Other options are valsiclovir 1 mg TDS and famciclovir 500 mg TDS. These are actually guanosine analogs and which inhibits viral thymidine kinase and inhibit DNA synthesis. In immunocompromised patients, intravenous therapy with acyclovir, foscarnet are the other options. Supportive therapy also includes antibiotics in the form of topical drops and ointments for secondary bacterial infections, corticosteroids to reduce inflammation, and anti-glaucoma drugs for secondary glaucoma and raised IOP with corticosteroids, and debridement in case of epithelial keratitis. So surgical management mostly considered for corneal complications, which include amniotic membrane transplantation, tarsorrhaphy. In small perforations, we can go for cyanoclear glue plus BCL application. And if it is larger corneal perforation and severe scarring, we can go for therapeutic penetrating keratoplasty. So vaccination, in case of herpes zoster, we have live attenuated vaccines, Zostavax, which has an efficacy of effectiveness of 51 to 70%, and newer subunit vaccines, it is more effective with 91 to 97% effectiveness. So other, we have Varizig, it is an immunoglobulin for passive immunity, it used in case of post-exposure prophylaxis within 4 days of exposure. Post-herpetic neuralgia, management includes tricyclic antidepressants like amitriptyline, nortriptyline, anticonvulsants like carbamazepine, gabapentin, and capsaicin cream. These are my references, and thank you.
Very good. I think you stuck to the time. Thank you so much. So Dr. Ritu, any comments? Ma'am? You're muted. Ma'am, you're muted. You need to unmute, ma'am.
I'm saying he did a good job in his limited time. presenting the salient features, but a little bit of modification is needed. What is the newer concept in the treatment of varicella zoster virus, herpes zoster ophthalmicus? Because you've given the dose of antivirals only for 1 week. So any idea what is the newer concept?
Newer concept, it was like systemic antivirals. It has shown in several studies that it has no role as such, but it helps in resolution of symptoms and reactivation of herpes zoster.
No, you're saying systemic antivirals have no role in herpes zoster ophthalmicus.
Yes,
In
ma'am.
herpes zoster ophthalmicus, systemic antivirals are the mainstay of treatment. They're the mainstay of treatment. Only thing you've written for 7 days, but nowadays there is being advocated for a longer period to avoid further complications. Otherwise, you did a good job.
Dr. Rashmi?
Yeah, I think within the limited time, he's covered it quite well. That is what my comment would be. Yeah.
Any questions or anything? Dr. Swati, ma'am?
I think very nicely presented, but as Dr. Ritu Arora said, that at least for 2 weeks, at least, you should not stop in 7 days. And secondly, the role of corticosteroids in this is very important. Loteprednol or any low-dose steroids have to be given for a very prolonged period of time because the inflammation keeps going on. So that you have to mention, that you have to give steroids later on when the epithelial defect is healed, because otherwise it won't. It's a good presentation.
Thank you, ma'am. Dr. Sharat sir?
Yeah, just wanted to know from the presenter, when do you give the vaccination? Which age group?
Sir, age group, those vaccinations which are mentioned, they are for more than 60 years of age.
Yes, very good. And any other patients? Particular categories?
Particular, like varicella immunoglobulin is used in case of immunocompromised patients and premature infants, and those babies whose mother is serologically positive within 5 days of delivery. In those patients, immunoglobulins can be given.
Basically, elderly patients who are going for the immunosuppressant treatment. Prior to that, generally, they do give the vaccinations. So, good. You did a good job.
Thank you, sir. So we'll quickly move on to the next team. The next team is the asteroids. So are you ready? Their topic is...
Excuse me, ma'am.
Yes.
Ma'am, we have our mentor joined.
Oh, yeah. Sorry. Yes, you have your mentor, Dr. Rakesh Porwal here.
No,
Yes, please.
Dr. Ankur Srivastava, sir.
Is he here? Has he?
Dr. Ankur, sir.
Yes, sir. Yes.
Ankur is there. Okay. Yes. Sorry, Dr. Ankur Srivastava. Hi, sir. Please.
Yeah, I'm Dr. Ankur. I'm Professor of Ophthalmology at AIIMS Raipur. And first of all, congratulations to YOSI for a wonderful, organizing everything is not so easy thing. So congratulations to YOSI team. And of course, our team did well, and I really like to congratulate the other teams, and all the best to the remaining teams who will be presenting the presentation. Thank you.
Thank you so much, sir. Thank you. So this iQuizzards gets +5 as well. And we'll quickly move to the next team. The next team is the asteroids. Their topic is the vernal keratoconjunctivitis. So can you please share your screen? Yes, yeah, we can see it. So can you go to the slideshow mode?
Oh, yes, ma'am.
Yes.
Is it visible, ma'am?
Yes, yeah, it's visible now. So your time will start now. Please begin.
Okay, good afternoon, everyone. Our topic is vernal keratoconjunctivitis, also known as the spring catarrh. So it's a chronic bilateral interstitial allergic inflammation of the cornea and conjunctiva, which typically presents in younger individuals, especially between 4 to 20 years of age, more commonly seen in boys in tropical areas, especially in summers. So the spring catarrh is a misnomer. So let's see the pathogenesis. So when there is a chronic allergic stimulus, it results in overactivity of the Th2 cells and the mast cell degranulation, which results in the release of histamine, cytokines, proteases, and interleukin 4 and 13, which are responsible for release of majorly eosinophils, lymphocytes, and neutrophils as well, which leads to chronic inflammation. So when there is persistent inflammatory reaction, it leads to fibroblast activation and proliferation of the cells in the conjunctival stroma, leading to deposition of extracellular matrix, which further leads to collagen accumulation and hyalinization, which results in thickening of the conjunctiva and formation of the papilla, especially in the upper tarsal conjunctiva. So now in conjunctival epithelium, there is hyperplasia and downward projection in the subepithelial tissue. In adenoid layer, there is marked cellular infiltration, majorly of eosinophils. In fibrous layers, there is proliferation of the fibrous cells followed by hyalinization, and there is increased permeability and vasodilation of the conjunctival vessels. Coming to the symptoms, there is itching, photophobia, ropey discharge, lacrimation, foreign body sensation, heaviness of the eyelids, ptosis and blepharospasm, and also pain and diminution of vision if the cornea gets involved, especially in case of shield ulcer. So let us see the types, the palpebral, bulbar, and mixed forms, and the one having corneal involvement. So in the palpebral form, majorly upper tarsal conjunctiva is involved, and there is presence of a typical cobblestone pavement appearance of the papilla, and it's also associated with ropey discharge. In bulbar form, there is dusky red triangular congestion of the bulbar conjunctiva. In the papillary area, there are limbal papillae as seen in the picture, and also Horner-Tronta spots, which are discrete white raised dots in the limbus. A mixed variety contains both the palpebral and bulbar form, and it is seen more commonly in the tropical countries, and in India, it is up to 72%. Now, the corneal involvement, there is punctate epithelial keratitis involving the upper cornea, mostly in palpebral form, and they always stain well with rose bengal. And then ulcerative Werner keratitis, there is shallow transverse ulcer in the upper part of the cornea due to the macro erosions. And there can be presence of plaques, which is due to coating with the altered exudates. Subepithelial scarring can also occur in the form of a ring. And there can also be a pseudogerontexon, which is basically, clinically, there's evidence of previous allergic disease. Treatment can be both non-pharmacological and pharmacological. Non-pharmacological involves avoidance of allergen exposure, protective measures, cold compresses, artificial tears, and patient education. In pharmacological treatment, in topical treatment, mast cell stabilizers like cromolyn sodium and N-acetyl aspartyl glutamate, and then topical antihistamines like levocabastin. More commonly, dual-acting agents, which have both immediate and prophylactic action because of the presence of antihistamines and mast cell stabilizers. They include olopatadine, which is commonly used, and azilastin. Topical NSAIDs like ketorolac, tromethamine, mucolytic agents like acetylcysteine, 0.5%. Then topical steroids, both low potency and high potency can be used. Chloromethylone 0.1%, loteprednol, they are both commonly used. In high potency, prednisolone and dexamethasone. Then topical immunomodulators, in this calcineurin inhibitors like cyclosporin and tacrolimus, and IgE inhibitors such as omalizumab, usually given subcutaneously, less commonly used. And biologics have also been tried like dupilumab. In systemic treatment, oral antihistamines like cetirizine and loratadine, oral steroids and oral immunomodulators. In surgical treatment, supratarsal injection of long-acting steroids, surgical excision of papillae, superficial keratectomy, excimer laser therapeutic keratectomy, and amniotic membrane transplant and limbal cell transplant in severe cases. Thank you.
Excellent. So thank you so much. Dr. Ritu, ma'am.
Yeah, I think she did a good job in the limited time of presenting the different aspects of VKC. One more thing I just want you to, for everybody's knowledge, re-emphasize what is the commonest accompaniment of VKC. Something which you need to rule out if you see a patient with VKC.
Ma'am, to differentiate with atopic keratoconjunctivitis.
No. If a patient of a VKC comes to you,
Yes,
there is
ma'am.
something else which you definitely need. You definitely need to rule out keratoconus in these patients. These
Keratoconus,
patients
yes,
have
ma'am,
to
due
be
to
on the
constant
long-term
rubbing.
follow-up
Yes, ma'am.
from the keratoconus point of view.
Yes, ma'am.
That is number one. And
Right.
second, you did mention about PTK. So what is it that you're referring to? You are going to do PTK of what?
Ma'am, there is photodynamic therapy, ma'am,
Which
in
photo? You are saying PTK,
Keratin-
phototherapeutic keratectomy.
phototherapeutic keratectomy. In this, ma'am, laser is used to basically excise the base of the, especially in cases when there is development of plaque. So to remove the plaque, to remove the superficial layer so that the epithelium can regrow and cover the area, ma'am.
Okay. Thank you.
Laser for laser ablation. Yes, ma'am.
Okay.
Dr.
Just one
Swati, ma'am?
question. Yeah, just one question. When would you use an amniotic membrane transplant?
Ma'am, in case of
You
severe
mentioned.
VKC, when there is, especially when there is development of shield ulcer because of constant rubbing due to the cobblestone papillae. So that time amniotic graft can cover the
Okay.
upper tarsal conjunctiva and
So
prevent.
there's anything that you can do before an AMT?
Ma'am, subconjunctival steroidal injections, ma'am.
Okay.
Triamcinolone. On debridement also, ma'am, debridement of the ulcer.
I have one question.
Yes, ma'am.
What are the typical features of a shield ulcer to differentiate from an infective ulcer?
Ma'am, shield ulcer, it has clear margins, ma'am. The base is also clear.
What else?
And it's typically present in the upper part of the cornea.
Okay. What else? So it is typically present in the upper part of the cornea. It is very typically a oval shaped ulcer without
Yes.
any inflammation and thickened epithelial margins. That is when you know that it is shield ulcer. And why is it important to differentiate it from an infective ulcer?
Ma'am, because the course of treatment changes accordingly, ma'am. If
Correct.
it is infective, then antibiotics have to be added, depending on the nature of the ulcer. If it is infective, then antimicrobials have to be started. But in VKC, the treatment majorly remains dual acting agents or steroids, ma'am. And
So
in steroids are contraindicated in few infective conditions, ma'am.
take it.
Yeah.
Sarath, sir?
I have one question. Why
Yes.
do you want to use the tacrolimus and cyclosporin? What is the main concern?
So it acts in the so to prevent recurrence, it's a long term for long term management of the disease.
Basically, it's a steroid sparing agent. We can't use the steroid for long duration.
Oh, right.
Due to the side effect of the steroid, we are just concerned about the side effect of the steroid. So
Okay.
tacrolimus and cyclosporin are needed such patients.
Okay.
Okay, thank you. Good job.
Thank you, sir.
Thank you. Thank you, everyone. I welcome their mentor.
Yeah.
I think Dr. Ritika Mulik is here.
Hello.
Hi. Can you please introduce yourself and say a few
Yes,
words?
I'm Dr. Ritika Malik, and I'm a cornea refractive surgeon at IKN Noida. And I would like to congratulate YOSI. I've been a part of YOSI since many years now. And I would like to congratulate them on such a good platform giving to these young postgraduates. And I would like to congratulate the other teams also. Good job and best of luck to everybody.
Thank you so much. Thank you so much for joining. So Team Asteroids also gets a +5. So it's very heartening to see that all teams have their mentors here. It's very nice that they have such good mentors and they're actively participating. So go way to go teams. So we'll have the next team now, the optic nerds. So their topic is peripheral ulcerative keratitis. So can one of you please share your PPT and start presenting?
Yes. One timer.
Dr. Samita, after this, we could have the second team go again.
Yes, yeah. After this, we'll
Yeah,
have the
yes,
multifocal
yes.
warriors.
The multifocal warriors can go after that.
Yes. Yeah, you can share your screen, optic nerds.
Is it visible?
No, it's not yet. Not yet shared. You can press share screen and go to your PPT.
Share. Slideshow.
We are still not able to. Yeah, we can see your PPT now. Please go to slideshow. Yeah, you can start now. Your time starts now.
Good afternoon, everyone. Today we'll read about peripheral ulcerative keratitis under these headings. Starting with the very first word of peripheral ulcerative keratitis, why peripheral? Peripheral cornea has many differences from the central cornea, but of importance here are it has got a lot of lymphatics and it's highly vascular, as anterior ciliary artery supplies 0.5 millimeters into the clear cornea, which along with blood can also bring a lot of infections, can also bring immunocompetent cells and complement cell, leading to autoimmune diseases, hypersensitivity reactions, and can also bring malignant cells. This will lead to type 3 hypersensitivity reaction, leading to activation of complement, neutrophils, macrophages, which will destruct anything that comes in his way by release of proteases, including MMP1 and 2, collagenases, and reduce the concentration of their inhibitors, leading to excessive stromal destruction by collagenolysis. So peripheral ulcerative keratitis, or PUK, is nothing but destruction of the corneal stroma starting just adjacent to the limbus, where in the epithelium we will see the defect with infiltration of crescentic shape in the stroma. We will see inflammatory cells and infiltration, which will eventually progress to melting and perforation. There is a distinct gap between the infiltration and the limbus, and this infiltrate which spreads circumferentially, with the leading edge showing more infiltration and has got a characteristic overhanging edges. In advanced cases, there would be corneal melt with, if severe, it will look like a contact lens cornea and it can eventually perforate. It can be associated with scleritis in 36 to 66% of the cases, signifying systemic association. There can also be limbitis and iritis, thus we definitely need to check the intraocular pressure. What will the patient come to us with? He can have redness, watering, decreased vision. If it is gradual, it is due to astigmatism, but if it is sudden, it has to be perforation. If there is severe pain associated, there can be scleritis, or if there is severe pain without scleritis, we have to suspect Moran's ulcer. There are multiple causes from infection. Any infection like Staphylococcus, Streptococcus, Moraxella, herpes simplex, herpes zoster, fungi, acanthamoeba, TB. And a non-infective includes corneal degenerations like Moran's ulcer, pellucid degeneration, Terrian degeneration. And the non-inflammatory, more commonly seen in OPD, we tend to forget, include blepharitis, marginal keratitis, exposure keratopathy, and after contact lens use. And then we have multiple systemic associations like the multiple connective tissue disorder, the most common being rheumatoid arthritis and vaginous granulomatosis and polyarthritis nodosa, where peripheral ulcerative keratitis can be their initial presentation. Thus, we need to do a complete examination of the body, where we need to look for the butterfly rash, abdominal pain, joint pain, seizures, mucosal ulcers, saddle nose deformity, etc. Before we make the diagnosis of PUK, we have to rule it out from other DDs, the most common being Moran's ulcer, which is a diagnosis of exclusion. Watson criteria states that it's highly painful, crescentic, with extensive undermining of the central edge, with dense infiltration at the leading edge, without associated scleritis and collagen vascular disease. This is how he classified it. Then we can, the other DD is Terriens, which involves a superior cornea where the epithelium is intact and has got lipid infiltration. Pellucid degeneration, on the other hand, involves inferior cornea and there is a crab claw appearance on topography. If there is association
associated blepharitis and lid telangiectasia, we have to think of acne rosacea and marginal keratitis, which is due to Staphylococcus exotoxins, whereas Staphylococcus can also cause phyllectinular keratoconjunctivitis in children, and in elderly, we need to rule out marginal furrow degeneration. A case of PUK, we have to refer to rheumatologist, and in the eye, we need to rule out the infections, we need to do dry eye evaluation, and we need to rule out scleritis, vasculitis, and associated uveitis. The goal of management should be to halt the progression, avoid secondary complication, minimize scarring, and save the vision. We need to start the patient on treatment after excluding the infection with the mainstay treatment of steroids. If the disease is unilateral, we start with topical steroids, which we need to avoid if there is severe thinning. If the disease is bilateral with systemic association, we start him on oral or IV methylprednisolone with all of these adjuvant therapy, which helps in healing. If it's not helping, we can just cut out the culprit. We can cut out the conjunctival vessels by doing conjunctival resection, which is done 3 to 4 mm from the posterior limbus. 4 mm from the posterior limbus. If the disease is bilateral, associated autoimmune disease and associated vasculitis, scleritis is there, we have to start on immunosuppression. If they're already complicated, we have to do surgery and nothing can be done. We do visual rehabilitation. If the impending perforation or small perforation, we apply glue BCL, or we can do amniotic membrane transplant. If there is localized perforation, we can go for corneal patch graft, corneoscleral patch graft. When the lesion is big enough, we do keratoplasty. Thank you so much.
Excellent. Dr. Ritu, ma'am?
Yeah, I think she did a good job considering the time constraint. It's a very big topic, so it's good. Yeah.
Thank you, ma'am.
Swati, ma'am, any comments,
Yeah,
questions?
I think she has presented really well and very comprehensive, and I think she has done full justice to whatever she could. Very well done.
Thank you, ma'am.
Thank you, ma'am. Dr. Rashmi, ma'am?
Yeah, same comments from me that she's comprehensively covered. Within 5 minutes, covering this topic is very, very difficult because there are so many things in POK, but she did well.
Thank you, ma'am.
Sharad, sir?
I have one comment. Can you share your slide of causes? I think that was a differential diagnosis you have mixed with the causes. So that is, in the beginning, you are not talk about the autoimmune conditions. In the investigation, you were talking about the autoimmune conditions. Basically, PUK, we are just dealing with the autoimmune to rule out the autoimmune conditions. So that is the most important.
Yes, sir, I have said in systemic association, sir.
Okay. That was the only glitch I thought in your presentation, because in causes, you have mixed the differential diagnosis. Otherwise, fine.
Okay. Thank you so much, sir. Thank you for your comments.
Questions from
So I
any of the
think you...
judges? Any questions from any of the judges? Because they get marked on the questions that they answer as well.
Okay. So you said about the conjunctival resection. So anything else you want to do along with conjunctival resection, or just conjunctival resection?
So like we continue the patient on steroids and immunosuppressant if needed, along with conjunctival resection.
Basically, it comes with cyanoacrylate glue BCL as well. And so that is the most important. And what is the role of that conjunctival resection? How it helps?
So like the vessels are coming from the conjunctiva itself. So we are just cutting down the culprit, sir.
Okay.
So the like all the immune or inflammatory cells and all, we are just cutting it out so that we can reduce the inflammation.
Yes. Okay.
Yes. Thank you, sir. Any other questions? Okay. So I think their mentor is also here, Dr. Professor Pooja Bang, ma'am. So, ma'am, if you could unmute, please introduce yourself and say a few words.
Yeah, good afternoon, everyone. And I would like to thank YOSI because their energy levels are trying to be matched by my residents, and they are so excited about this new contest, and they've been showing post-ops and they've attended a glaucoma rally since morning and still they are here. And so congratulations to both YOSI and to our team. Thank you so much.
Thank you so much, ma'am, for your words. And I think your encouragement goes a long way in motivating these students. And it's such a great learning experience for them. Thank you so much for joining us. And the optic nerds get a +5 as well. Okay. So I think we have the last team to present now, which is the multifocal warriors. They are team number 2, actually. So guys, are you ready with your presentation? Their topic is corneal dystrophies. Yeah, please share your screen. Yeah, we can see it. Go to slideshow. Yes, correct. Yeah, I think that's fine.
Good afternoon, everyone. Today I will be discussing about the corneal dystrophies. These are the non-inflammatory corneal opacifying
Again,
disorders.
she's on first slide only.
Yeah, your slides are not moving. Ranu, can you go back to slideshow? Can you press it again? It's not gone into slideshow mode. Yeah, just press that again. Is it working?
Ma'am, now it's moving?
No, it is not in the slideshow mode yet. It is still in your screen mode itself. Yeah, slideshow, can you press from beginning?
Ma'am, now it's
Dr. Samita, I think we can share from our end. They're having a lot
Yeah,
of difficulty.
okay. Yeah. Can you stop sharing?
Multifocal warrior, you can just ask us to move the slide, all right? In case we're not proceeding at your pace, all right?
Okay, so you can stop sharing. I'll share it from my end. And when you want to go to the next slide, you say next. I can share it. Okay, shall we do that? If you stop sharing, I can share it from my end.
1 second, ma'am. Is it moving now?
Not really. Can you go next? It's moving in the PPT, but we can't see it in slideshow mode. Is that okay? Like, judges, can we go ahead
Yeah,
with
that
that?
is okay. That is
Okay,
okay.
fine.
She
Then
can
you
just
can
click.
continue.
She can just click on the next
Yeah,
list.
she can just
Okay.
click on next. Okay, yeah, then you can continue. Yes.
Good afternoon, everyone. Today I will be discussing about the corneal dystrophies. These are the non-inflammatory corneal opacifying disorders, usually inherited, bilateral symmetrical, with no relation to the systemic or environmental factors, gradually progressive. They begin early and they are centrally located. Let's start with the epithelial and subepithelial corneal dystrophies. Most the main complaint patient come with in the
It's still
epithelial.
not moving. Your slides are not moving now. Now, yeah. Okay, go ahead.
Patient come to us with the epithelial dystrophy. The main complaint is recurrent epithelial erosions and the transient blurring of vision. Most common is the epithelial basement membrane dystrophy, also known as the map dot fingerprint or the Cogan dystrophy. And it is TGF-B1 gene involvement. More than 50 years of age patient, and in slit lamp, fine lines and the microcysts are seen. In histology, there is thickening of the basement membrane with deposition of the fibrillary protein, and it's treated with the 5% NaCl drops, lubricating drops, debridement, and excimer laser. Then Meesmann epithelial dystrophy. Here the gene encoding for the epithelial keratins is involved, and tiny intraepithelial cysts are formed here. There is irregular thickening of the epithelial basement membrane with intraepithelial cyst, and the fibrogranular material is deposited within the cyst. It's treated with the lubricants and the soft contact lenses. Then we have Lish epithelial dystrophy, also known as band-shaped Wold microcystic dystrophy. It's X-linked dominant. Here, the diffuse grayish-white epithelial opacities with the microcysts are seen, and vacuolization of the epithelial cells are seen. Now the dystrophies for the Bowman's layer. Then Reese-Buckler corneal dystrophy. It's the most common type of Bowman dystrophy. It's the severe form of dystrophy. Here the Bowman layer is replaced with the connective tissue, and the white geographic subepithelial opacities are seen that coalesce to form the reticular pattern. Then we have Thiel-Benke corneal dystrophy, also known as the honeycomb dystrophy. Here the subepithelial fibrosis due to the deposition of curly collagen deposition is seen. Then in stromal dystrophies, we have first granular corneal dystrophy type 1. Here the sharply demarcated grayish white opacities are seen in the anterior stroma. It spares the limbus with the deposition of hyaline material that is stained by the Mason's trichrome stain. Then we have granular corneal dystrophy type 2, also known as the Avellino dystrophy. It's the combined form of dystrophy where in anterior stroma, granular deposits of hyaline seen, and in posterior stroma, lattice type deposition of the amyloid is seen. In epithelial erosions, we use therapeutic contact lenses and the artificial tears. And in superficial involvement, superficial keratectomy, lamellar keratoplasty, and phototherapeutic keratectomy is done. In case of deep involvement, penetrating keratoplasty is done. Then macular corneal dystrophy. It's the least common dystrophy involving the CHST6 gene with autosomal recessive pattern. This type of dystrophy extends up to the limbus with the deposition of glycosaminoglycans that is stained with the Elchian blue and the colloidal iron. Then we have lattice corneal dystrophy, where the amyloid deposits are seen in the anterior stroma that stains with the Congo red. It's treated with the patching, hypertonic agents, contact lenses, superficial keratectomy is done. And in very severe cases with a visual loss, we go for the deep anterior lamellar keratoplasty. Lattice type 2 is the Meritoja syndrome. Here, the systemic amyloidosis is also seen together with the facial involvement. Then we have Schneider corneal dystrophy with the UB1 AD1 gene involvement. The characteristic feature is the dense arcus with deposition of cholesterol and phospholipids that stain with the oil red O stain. Then we have Descemet membrane and endothelial dystrophies. Most common is the Fuchs endothelial corneal dystrophy that presents in more than 50 years of age with the TCF4 and COL8A2 gene involvement. Here, the abnormal production of collagenous material is seen with its deposition in the Descemet's membrane, and hence the sodium-potassium pump is hampered. NaCl drops are used, IOP lowering agents are used, bandage contact lenses used, and the surgical procedure that we use is DSAC or the DMAC. Then it's posterior polymorphous dystrophy. Here the focal metaplasia of the endothelial cells is seen. Then we have congenital hereditary endothelial dystrophy involving the SLC4A1 gene. Here the blue-gray opacities with the total opacification seen in children. Some of the key points that you have to remember is dystrophy is present early, except for the Fuchs dystrophy that presents in 50s. All are autosomal dominant except the Lish dystrophy that is X-linked dominant. And in macular dystrophy, congenital hereditary type 2 and gelatinous, it is autosomal recessive. And the majority gene involved is the TGF-B1 gene. And in case of endothelial dystrophy, the main characteristic feature is the IOP raised, and for that we have to give the IOP lowering agents. Thank you.
Thank you so much. Dr. Ritu ma'am, any questions?
Yeah, I think she did a good presentation. Again, I think you've chosen very vast topics and given them only 5 minutes per presentation. So in that much time, she's done a good presentation. So, Bacha, if I have to ask you, how do you differentiate clinically between a granular dystrophy and a macular dystrophy? Sometimes at the level of residence, you get confused. So clinically, how would you differentiate between them?
Ma'am, first
You just
of
have to
all,
give me 3 points for that.
yes, ma'am. Symptomatically, in case of macular dystrophy, the patient comes with the more transient blurring of vision as compared to the granular dystrophy. There is more vision loss in case of macular dystrophy. And in case of signs, macular dystrophy usually extends up to the limbus. Generally, they start from the periphery and then they come to the centrally. But in case of granular dystrophy, they start centrally and then go periphery, sparing the limbus.
That is one point. Limbus involvement or limbus not involvement, right?
Okay.
What are the other points?
Um, Ma'am, histologically, if we see...
No. Clinically, histology is later. So what is the intervening cornea like in granular dystrophy and intervening cornea in macular dystrophy? You have deposits, isn't it?
Yes, ma'am.
So what is the intervening cornea?
Ma'am, generally, in case of macular dystrophy, the intervening cornea is also hazy as compared to the...
That's what it is. So intervening cornea is absolutely clear in granular dystrophy, while
granular
it is
dystrophy.
involved in macular. And what is the third point? What is the corneal thickness like between the two?
Ma'am, in between the two, in case of granular dystrophy, the corneal thickness remains normal. They are very demarcated lesions. Whereas in case of macular dystrophy, the intervening cornea, the thickness is is increased due to the haziness and
thickness is lesser. In macular corneal dystrophy, the thickness is lesser, while in granular corneal dystrophy, thickness is preserved or may be increased. That's all. Thank you very much.
Thank you, ma'am.
Thank you.
I'd ask a question that what diagnostic techniques that you can use, when you are going also thinking of a surgery? What investigations would you like to do in such cases?
Ma'am, while going for the surgery, the most essential is the corneal thickness measurement. So if we are going for the surgical measures, like ma'am, CCT is the main parameter that we have to look for. And
Is
for
there
that,
anything else that you can do?
ma'am, ASOCT can be done.
Right. Yeah, that's okay.
Thank you, ma'am.
Thank you, ma'am. Dr. Rashmi, ma'am.
No questions from my side.
Okay. Shad, sir, anything? Any questions you want?
Just one question. Why do you want to categorize into epithelial, stromal, and endothelial dystrophy?
Sir, to plan for the further treatment and also to plan for the surgical procedure, it's very needed that which layer is involved so that we can opt for the better surgical procedure. If we
Very
have
good.
to.
Very good.
Thank you, sir.
Thank you so much, sir. So I think their mentor is also here, Dr. Rakesh Porwal. Sir, could you log in and say a few words, please?
Ma'am, sir is here only.
Yeah, yes, please. Hello, sir.
Good afternoon, everybody. It has been an incredible journey of YOSI for providing such a good platform to our residents of JLN Ophthalmology Department. Although the topic is cornea, but I would just like to remember all of us that today is World Glaucoma Week also. I would like to congratulate you all for it. My residents have worked very hard with a lot of dedication. They are doing a lot of keratoplasties with us, and the most important thing is that you have provided a wonderful platform for these residents to come out and show ourselves. Winning or losing is not a problem. The problem is that we are interacting with each other and making the new masters, the new teachers of JLN Medical College, as well as of whole of the India. Thank you very much.
Thank you so much, sir. Wonderful words. And as you said, yes, winning or losing is not the most important thing. I think it's a very good learning experience and the teams get to learn a lot. And your residents doing keratoplasty is an amazing thing. Congratulations, sir. And thank you for joining us. So team multifocal warriors also get a +5. So all the teams get a +5 in this round because all their mentors have been here. And excellent presentations, everyone. So we shall quickly move on to the next round. So we are done with the round 1 now. And I would quickly share my screen here. So the round 2 is Pupils Got Talent. So we'll get into the round quickly. So can you all see my slide here?
Yes, we can see it. Can you
Yeah,
go
okay.
full
So
screen?
round 2
Yeah.
is Pupils Got Talent. So the team members will collaborate to give a creative presentation. It could be in the form of a reel, music, dance, etc. on the topic of interest. Theme is cornea. So anything related to awareness regarding cornea was the theme. So 20 marks will be there for each team for this round. Judges, the marks to be given on the basis of creativity, 5 marks, content and flow, 5 marks. Relevance to the theme, 5 marks, and overall presentation, 5 marks. So totally it will be 20 marks and it will be 2 minutes per team to present. The teams have already made the reels and send it. So I will be playing the reel here. I would like to ask the judges here that would you like to have the comments after each presentation or at the end of it after I play all the reels? Judges,
I
your
would
input.
suggest at the end of it because
Yeah,
that will save time.
Yes, yes,
right.
sure, ma'am. So I will just be playing the reels one by one along with the team names. And then at the end of it, we can have the comments. Okay, so let me just quickly share my share the first team here. So the first team is the eye catchers. So let me just share it here. So this is the reel from the eye catchers. Please let me know if you can hear the audio.
I'm
Is
not
it audible?
LASIK, but I fix your sight. I work in the dark, but you see in the light. Not
Samrita,
permanent,
can you
but I
shift the screen to the one that shows the video? We can just see your full
Okay,
file
okay.
explorer option. Yeah.
Acha, right.
And the
Okay.
audio was working.
Yeah, audio is working. Wait, let me just stop share and share it again to the screen which has the video. Okay, audio is playing. No? Okay. Yeah, so I'll start this. You can see the screen now?
Yes.
Yes, so this is the team eye catchers. So the
I'm not LASIK, but I fix your sight. I work in the dark, but you see in the light. Not permanent, but I do my best to give your eyes a daytime rest. Who am I? Hey there, parents. Looking for a way to help your kids see clearly without the hassle of glasses or daytime contacts? Let me introduce you to orthokeratology lenses, or ortho-K for short. These magical lenses work overnight to give you clear vision all day long. So what exactly are ortho-K lenses? Well, they're rigid gas-permeable contact lenses designed to temporarily reshape the cornea. You wear them while you sleep and wake up with improved vision. It's like a mini makeover for your eyes every night. How do they work? These lenses gently flatten the cornea while you catch those Z's. This reshaping adjusts how light enters your eye, reducing refractive errors like myopia or nearsightedness. The effects last about 24 to 48 hours, so you'll need to wear them consistently every night. Who can benefit from ortho-K lenses? They're great for children with progressive myopia, helping slow down its progression. Adults with mild to moderate myopia who aren't ready for LASIK might find them a fantastic alternative. Athletes and active individuals who prefer a lens-free daytime vision would love them too. Plus, if you have dry eye syndrome and struggle with soft contact lenses, Ortho-K could be your solution. Now, let's talk benefits. Enjoy clear vision all day without any corrective lenses. Ortho-K lenses can slow myopia progression by 30 to 50%. They're a reversible, non-surgical alternative to LASIK. Perfect for sports and outdoor activities. But like all good things, there are some limitations. The effect is temporary, so you must wear them nightly. Strict hygiene is crucial to prevent infections. You might experience glare, halos, or mild discomfort initially. And yes, the upfront cost can be higher compared to regular lenses or glasses. The fitting process involves a comprehensive eye exam, corneal topography mapping to design custom lenses, trial fittings, and regular follow-ups to monitor eye health. So, if you're looking for a modern, non-invasive way to help your family see clearly, consider giving Ortho-K lenses a try.
Thank you.
So I think a very good reel on ortho-K lenses. So we'll quickly move to the next.
One comment here. Sorry, I'm intervening.
Yes, ma'am.
These reels have been made by the teams, or they've been taken from the internet.
No, ma'am, it has been made by the teams.
I doubt
we are
it.
given.
I doubt
It's a AI. Basically, they have written iStock Getty images, something like that. So I'm really surprised what
Yeah, this
we
is
are
not
going to
original.
judge. Yes, not original.
This is not original, and it looks like as if you are advertising for a orthokeratology, whatever the contact lens is for orthokeratology.
Yeah, we had told them to make the reels or videos.
No, this is not.
themselves,
You
ma'am.
can
So
see,
I think
you
it
have
can-
all the foreign patients and this, so it cannot
Yeah.
be an original team, and I don't think I'd
Correct.
like to mark on this.
Basically, it is written there, iStock Getty images. It's some
Yeah.
AI is there.
It's absolutely
Eye-catchers.
unfair. It's very unfair.
Yeah. True, ma'am. Eye catchers team, you want to say anything?
Hello. Yeah, ma'am. It is made from InVision AI, but ma'am, we have put some images. We have done some changes. Like,
See,
ma'am,
it's
in
a creativity. It's a creativity. We are judging among the human beings, not with the help of AI.
yes, in past sessions also there are many videos all made of AI.
It could be there, but I think our whole idea to give this round was to see what you can do with it and how you can make a creative reel or video out of it and not just modify the things. I think we will take the judges' comments on this one and let's see, we'll see all the reels and I think they will mark accordingly. Okay. Shall I go to the next reel?
Yes.
Yes. I'll just play it. So the next team is the multifocal warriors. So they are the team 2. I'll quickly share the thing. 1 second. Give me a second. So I shall. Yeah. Okay. So this is the reel by team multifocal warriors.
एक ट्रांसपेरेंट सुपर हीरो जो आपको दुनिया देगी, लेकिन क्या आप उसकी कदर है?
अरे ये क्या कर रही हो? मत करो ऐसे। मैं बहुत ही पतली सी लेयर हूँ, सिर्फ टीयर फिल्म के भरोसे रहती हूँ। अरे ऐसे मसलने से इन्फेक्शन हो जाएगा।
कॉर्निया सिर्फ आधे मिलीमीटर पतला होता है। आंख को रगड़ने मसलने से कॉर्निया की थिकनेस और कम हो जाती है और ये आंख में छम, इन्फेक्शन और केरेटोकोनस जैसी गंभीर बीमारियां कर सकती है जो आपकी नजर छीन सकती है।
और ये देख कैसी सूख सी गई हूँ मैं, अंधेरे में चलाई जा रही है, फोन चलाई जा रही है, थोड़ी तो पलक झपक।
फोन की नीली रोशनी आपकी आंखों को नुकसान पहुंचा सकती है, इसलिए सोने से पहले फोन को बंद करें और अपनी आंखों को आराम दें ताकि आप भी आराम से सो सकें। सोते समय आंखों में कॉन्टैक्ट लेंस लगाने से आंख में इंफेक्शन का खतरा कई गुना तक बढ़ सकता है। आपके आंखों में कॉर्निया को भी ऑक्सीजन की उतनी ही जरूरत है जितनी आपके शरीर में। क्या आपको पता है मरने के उपरांत एक हेल्दी कॉर्निया एक से ज्यादा लोगों को दृष्टि प्रदान कर सकती है। आज ही कॉर्निया डोनेशन का प्लेस कीजिए।
कॉर्निया हमारी अनमोल हिस्सा है जो हमें दुनिया को साफ और सुंदर देखने में मदद करता है। इसकी देखभाल करना हमारी जिम्मेदारी है। आंखों को रगड़ने से बचें, सही मात्रा में पलकें झपकाएं, स्क्रीन टाइम कम करें और धूप में हमेशा चश्मा पहनें। यदि आप कॉन्टैक्ट लेंस का इस्तेमाल करते हैं तो स्वच्छता का पूरा ध्यान रखें। सबसे जरूरी बात, नेत्रदान का संकल्प लें ताकि आपका उजाला किसी और की दुनिया को रोशन कर सके। अपनी कॉर्निया को सुरक्षित रखें क्योंकि दृष्टि ही दुनिया की सबसे बड़ी सौगात है।
Excellent. So, will I share the next reel? Any comments from the judges?
Wait a minute. Ma'am, sorry to interrupt. Ma'am, sorry to interrupt, but
Ma'am, most of the things, ma'am, video quality has been degraded in this reel, ma'am, and ma'am, सब चीज कट के आ रही है. We are not able to.
Okay. Was it like that for everyone?
music, background music is also.
Ma'am, can we please play it from our side, ma'am? Because most of the background music and also the dialogues that we have put it, ma'am,
Okay.
Are
it's
not clear.
coming.
Are not clear.
Okay. So, can we have them play it, Dr. Rashi?
Ma'am, if you allow.
If the judges
ma'am.
allow,
We'll
ma'am,
play
can
in
we?
the last. We'll see other waves
All
and
right. So
let them
we'll make you
prepare.
go again multifocal at the end after optic nerves.
Okay.
Okay.
Sure. Yeah, be ready with your thing. So, I will let you. So, any comments, judges? I'll quickly share the next one. But meanwhile.
No, next you can.
I thought we would comment at the end of the whole reel.
Yes, ma'am. It'll take me a second to share the other one. So just give me 1 second. All right. Yeah. So the next team is the iQuizzards. So their reel is here.
Here is our humble attempt to spread awareness regarding eye donation and debunk a few myths. But before that, let's start with the background knowledge. As we all know, cornea is a crystal clear membrane in front of the eyes. But sometimes this membrane becomes deformed and cloudy. That's what we call as corneal blindness. A multitude of factors can be causative, be it accidental injuries or chemical spillages, congenital disorders and dystrophies, malnourishment and vitamin A deficiency, myriad of corneal infections and post-surgical sequelae. As per the National Blindness Survey, in age 0 to 49, corneal opacity is the leading cause, and in more than 50 years, the second most common cause of blindness. But do we have a solution? Yes, the diseased cornea can be removed and replaced with a healthy donor cornea, also known as corneal transplantation. But there are a few hurdles. There is a huge backlog of waiting lists for corneal transplantation. Roughly 13 lakh people in India are bilaterally blind. And to add on to that, we just had less than 50,000 cornea donations, of which only 30,000 were used. So there is a huge need. For those who can donate eyes after death should contact the nearest eye bank, as corneas can be donated within 6 hours of death. To save the corneas from drying, close the eyes and keep them moist. Turn off the fan and AC. On receiving information, a team reaches the site and very neatly and quietly starts the process of cornea retrieval. The donor cornea is safely collected and put into a preservative medium so that it can be transported back to the eye bank safely. Care is taken so the donor body is not disfigured and sanctity of body is maintained. On reaching the eye bank, the donor tissue is evaluated. After running a few tests, if the donor tissue is eligible, the most deserving patient is called for corneal transplantation. A single donor can give vision to up to 2 to 4 patients based on type of surgery. I would like to end by saying, Jeete Jeete Raktadaan, Jate Jate Netradan.
So nice reel there. So the next team is the team Asteroids. So I'll just quickly share their reel. Yes, so team Asteroids is here. Yeah, so this is the team Asteroids reel.
आपके जो आँख में चोट आई थी कुछ साल पहले, उसके कारण आपकी पुतली पे निशान पड़ गया है। ये निशान काफी गहरा है, तो ये किसी चश्मे से हम सुधार नहीं कर सकते।
Can you please raise the volume?
Yeah.
और इस पुतली बदलने के ऑपरेशन के लिए किसी की मृत्यु जब होती है तो उसकी दान की हुई पुतली हम इस निशान की पुतली से बदल देते हैं। तो उसमें हम कोशिश कर सकते हैं कि आपकी नज़र के जो सुधार है वो हो सके। आप अभी काफ़ी कम उम्र के हैं, तो इसीलिए हम कोशिश करेंगे कि जितनी अच्छी पुतली हो वो आपकी आँख पे बैठा सके। ठीक है, लेकिन इसके लिए आपको हम इंतजार करना पड़ेगा, जब कोई पुतली दान करेगा तो ही हम बैठा सकते। ठीक है। हेलो,
आप आइडिया दान केंद्र से बात कर रहे हैं?
जी बोलिए।
जी, हमारे चाचा जी की अभी मृत्यु हो गई है। उनकी आखिरी इच्छा थी कि हम उनके पुत्री को दान कर दें ताकि किसी जरूरतमंद के काम आ सके। तो क्या रहेगा, आप आ सकते हैं?
जी, मृत्यु कितने बजे हुई है?
जी, 4 घंटे हुए हैं।
और आप कहाँ से बात कर रहे हैं?
मैं सेक्टर 30 नोएडा में सरकारी अस्पताल से बात कर रही हूँ।
क्या आपको मृत्यु प्रमाण पत्र मिल गया है?
हाँ जी, मिल गया है। उनके दिल के दौरे के कारण मृत्यु हुई थी।
ठीक है, मैं अपनी टीम को लेके अभी आ जाती हूँ आपके पास।
ओके, धन्यवाद।
इस अस्पताल का मैं शुक्रिया अदा करना चाहती हूँ तहे दिल से, जिन्होंने मुझे पुतली दी है। मैं अपनी पढ़ाई दोबारा से शुरू कर सकती हूँ। इस अस्पताल का भी मैं शुक्रिया अदा करना चाहती हूँ, जिसकी वजह से मैं दुनिया देख पा रही हूँ। जब मैं शायद अस्पताल में आई थी तो मुझे कुछ नहीं दिख रहा था, तो मुझे लगा कि मेरी दुनिया ही खत्म हो गई है। तो जब मैं आई तो आप लोगों ने इस अस्पताल में मेरे लिए बहुत कुछ किया, और मेरी पुतली बदलने के लिए आपको शुक्रिया करती हूँ मैं, और उनका भी जिन्होंने अपनी पुतली मुझे दान की है, उनका भी मैं तहे दिल से शुक्रिया अदा करती हूँ। थैंक यू। नेत्रदान मृत्यु के बाद ही किया जाता है, और नेत्रदान मृत्यु के 4 से 6 घंटे के बीच में ही किया जाता है। इसमें एक प्रशिक्षित चिकित्सक द्वारा ही नेत्रदान किया जाता है, और इस प्रक्रिया में 15 से 20 मिनट ही लगते हैं।
यह नेत्रदान आप किसी अस्पताल में भी कर सकते हैं या आप घर में भी कर सकते हैं। संक्रमित बीमारी की क्षमता को दूर करने के लिए कुछ मात्रा में मृतक का खून लिया जाता है, और इस प्रक्रिया में मृतक का चेहरे में कोई विरूपता नहीं आती है।
नेत्रदान किसी भी जाति से सीमित नहीं है, और नेत्रदान में दान करने वाले का और जिस मरीज को दान मिल रहा है, उन दोनों की पहचान को गुप्त रखा जाता है। जीवन का अमूल्य वरदान, नेत्रहीन को नेत्रदान।
So then we have the last reel by team Optic Nerds. After that, we will have the multifocal warriors play their reel. Be ready. I'll just share the Optic Nerds reel now. Just give me a second. So sharing the, yeah, this is.
नमस्कार दोस्तों, देखा आपने इनका रिफ्रैक्टिव सर्जरी नहीं कराने का नतीजा। यही इन्होंने रिफ्रैक्टिव सर्जरी करवा ली रहती तो न गिरता चश्मा और न ये पकड़े जाते। आप भी रिफ्रैक्टिव सर्जरी करवा सकते हैं अगर आप 21 साल के ऊपर है और आपका पिछले 1 साल से चश्मे का नंबर स्टेबल है, अगर आपकी पुतली का क्वालिटी अच्छा है और आप ऑटो इम्यून नामक कोई बीमारी नहीं है और आप प्रेग्नेंट नहीं है। उसके लिए आपको नजर की जांच करवानी पड़ती है, चश्मे के नंबर की जांच, आंख का प्रेशर और आपकी पुतली का स्कैन करने के बाद आपको किस तरह का ऑपरेशन करना है उसका डिसीजन लेते हैं। 3 तरह के रिफ्रैक्टिव सर्जरी होते हैं, एक है पुतली बेस्ड, लेंस बेस्ड और तीसरा पुतली एंड लेंस बेस्ड। इस ऑपरेशन के साथ छोटी मोटी जटिलताएं कुछ केसेस में हो जाती है, जैसे कि ऑपरेशन के बाद आंख में सूखापन, या आंख में एक छोटा सा दाग रह जाना या 100% नजर का न ठीक हो पाना। बट ये ऑपरेशन आपकी पूरी जिंदगी बदल देगा। यही ऑपरेशन अगर ये बच्ची ने कराया होता तो उसकी किस्मत बदल जाती। आइए देखते हैं कैसे। तो इसी तरह आप अपना जीवन और अपना नजरिया बदल सकते हैं। तो सावधान रहे, सतर्क रहे और अपना ध्यान रखें। धन्यवाद। मिलते हैं अगले एपिसोड दिल्ली में।
Ma'am, sorry to interrupt, but the video didn't get played as.
Your voice is echoing. This is, can you tell me again?
Ma'am, actually, the video did not play as we had made, ma'am.
Optic nuts, you have two devices logged in the same room. If you could just switch one of those off, then we'll be able to hear you better. Till the time they are voicing what their comments, multifocal warriors, be ready to screen share, please. If Optic nuts, you want to also show your video again, you're allowed to, as long as the judges are okay with it. Because I think there's a problem at on the sharing portal. Swati ma'am, Ritu ma'am, Sharad sir, Rashmi ma'am.
They can share it.
Yes.
Yeah.
Please go ahead. Don't waste time. Multifocal warriors, please go first.
Are you there? Are you ready? Multifocal warriors?
Optic nerds, are you ready?
Yes, ma'am.
All
Yeah,
right,
okay, you can
start
share
screen
yours.
sharing.
Yeah. Who is sharing now? Is it multifocal or optic nerds?
Optic nerds. The judges, the rest of the reels were clear to you, or do you want a repeat of any of the others? Was there a
No,
problem?
others
The
were
last
fine.
one was pretty clear, I would say that.
Yeah, then we played it as the, but they're
Optic
saying it's
nerds
not
was
as
pretty
in
clear. The message did come across. Whatever they wanted to convey, at least came across.
राहों का रास्ता मुस्कानें झूठी हैं, पहचाने झूठी है, रंगीनी है छाई फिर भी राहों का रास्ता मुस्कानें झूठी है, पहचाने
You've stopped your screen share.
You've paused your video. Optic nerds, have you paused your video? Ma'am, I think we can go ahead.
Yeah,
with the
I think we
second.
can go
You already
with,
gave the
yeah.
rent. Yes. Multifocal warriors, please share your screen.
मेरी कॉर्निया से एक ट्रांसपेरेंट सुपर हीरो जो आपको दुनिया देगी, लेकिन क्या आप उसकी कदर है?
अरे अरे ये क्या कर रही हो? मत करो ऐसे। मैं बहुत ही पतली सी लेयर हूँ, सिर्फ टीयर फिल्म के भरोसे रहती हूँ। अरे ऐसे मसलने से इन्फेक्शन हो जाएगा।
कॉर्निया सिर्फ आधे मिलीमीटर पतला होता है। आंख को रगड़ने मसलने से कॉर्निया की थिकनेस और कम हो जाती है और ये आंख में छम, इन्फेक्शन और केरेटोकोनस जैसी गंभीर बीमारियां कर सकती है जो आपकी नजर छीन सकती है।
अरे लड़की, थोड़ा सा आंख तो झपक ले। देख कैसी सूख सी गई हूँ मैं। अंधेरे में चलाई जा रही है, फोन चलाई जा रही है। थोड़ी तो पलक झपक।
फोन की नीली रोशनी आपकी आंखों को नुकसान पहुंचा सकती है, इसलिए सोने से पहले फोन को बंद करें और अपनी आंखों को आराम दें ताकि आप भी आराम से सो सकें। सोते समय आंख में कॉन्टैक्ट लेंस लगाने से आंख में इन्फेक्शन का खतरा कई गुना तक बढ़ सकता है। आपके आंखों में कॉर्निया को भी ऑक्सीजन की उतनी ही जरूरत है जितनी आपके शरीर में। क्या आपको पता है, मरने के उपरांत एक हेल्दी कॉर्निया एक से ज्यादा लोगों को दृष्टि प्रदान कर सकता है। आज ही कॉर्निया डोनेशन का प्लेज कीजिए।
कॉर्निया हमारी आंखों का एक अनमोल हिस्सा है जो हमें दुनिया को साफ और सुंदर देखने में मदद करता है। इसकी देखभाल करना हमारी जिम्मेदारी है। आंखों को रगड़ने से बचें, सही मात्रा में पलकें झपकाएं, स्क्रीन टाइम कम करें और धूप में हमेशा चश्मा पहनें। यदि आप कॉन्टैक्ट लेंस का इस्तेमाल करते हैं तो स्वच्छता का पूरा ध्यान रखें। सबसे जरूरी बात, नेत्रदान का संकल्प लें ताकि आपका उजाला किसी और की दुनिया को रोशन कर सके। अपनी कॉर्निया को सुरक्षित रखें क्योंकि दृष्टि ही दुनिया की सबसे बड़ी सौगात है।
Okay, so we have all the reels played now. So I would invite the judges to give their comments. So Ritu ma'am.
Yeah, I think all of them were pretty informative except the first one. So I just had an objection to the first reel because that was, I feel it was not actually prepared by the team, and otherwise two were pretty replicative on eye donation, and the information which came in refractive surgery I think could have been better. And so yeah, all in all a good attempt, I just want to say.
Swati ma'am.
Yeah, I would voice the same sentiments as Professor Ritu Arora because, eye donation is, and to learn about that in your residency is very, very important. And I realized that both the teams, when they chose the myths and, other things, and actually they showed a video of an in situ excision, which is so good. There are lots of medical colleges in India where this has not been practiced, not even done. So I think overall the presentations were excellent and very creative.
Rashmi ma'am.
Yeah, I think after looking at the other reels, I would agree that the first reel did have a lot of, I mean, it was not original and they were supposed to use their creativity like the other videos did. The rest of them, at least they had made their own attempts and efforts and for their own dialogue videos. So yeah, that effort was missing with the first one.
Sharat sir?
I think they did a good job. So only hope that again they will not make the same mistake. So that's a learning. It's okay. It's a learning for everyone. So this is a take-home message from this session, I think.
Yeah, any improvements you would like to suggest? I would like to ask any of the judges. Any improvements or things they would like to include in the reel?
I think in the second one, the audio quality again was not all that great. And the picturization of all the myths could have been dealt a little better manner. And the eye donation, the third reel I felt was pretty good. And fourth one was, because third and fourth both were an eye donation, but depicted in a different manner. And the third one was more informative than the fourth one, which came across. Yeah, and refractive surgery seemed a little more pictorial. No, yeah, it could have been. I mean, more facts could have been given.
Okay, thank you so much, ma'am. So I think it was like a wonderful session with all the reels and the awareness. I asked Dr. Arshi to thank our judges. And,
Thank you so much to everyone. I'm sorry for my bad connection over here, but you've taken out so much time and you've given them such valuable comments. They are all going to give you their exams and you are going to be the examiners. So they should really learn from every single thing. And I commend all the teams and their mentors for guiding them and for teams for making an effort. It takes a lot of courage to be on this platform, be live on YouTube and still present and be open to suggestions and constructive criticism. So kudos to all of you for having done a good job. As ma'ams and sirs said, that you should just, try and use your creativity in a manner that is probably a little more presentable or come, your audience can accept it a little better. For example, Indian faces, use your own audio at least. So those kind of things make it better. And if you keep a very key concept that comes through very clearly, that makes it easier for the audience to like and accept your videos. But I think it's a very good job, and thank you so much, judges, and thank you so much, mentors. And if Dr. Samita would move ahead, we could present our judges with their certificates just as an honor
Certificates,
from
yes.
YOSI iROCK team and from YOSI. And if after that we could have all the teams switch on their camera, so we could have a picture with the judges, and then our judges for their valuable time. Thank you. If you want to stay on, we would love it. But if you can't, we understand. We can move ahead with the quiz and the unscramble round after that.
Yeah,
So
so
Dr.
this is
Ritu
Dr.
Arora.
Ritu Arora.
Thank you.
Thank you,
very
ma'am.
much. Thank you.
Thank you so much. Thank you.
Dr.
Dr.
Swati Tomar,
Swati
ma'am.
Tomar, ma'am.
Thank you.
This is Dr. Rashmi Deshmukh, ma'am.
Thank you.
And Dr. Sharad Gomse, sir.
Thank you.
So
I can tell
thank
you
you so
personally,
much.
having seen your CVs, I mean, we see a lot of people's, but it was so inspiring for us also that this is how much a person can accomplish. So there's a long way for us to grow as well. I think
And
that's
thank
what
you for sparing your
participants
valuable
can
time,
look forward to.
on a Sunday afternoon and coming here to encourage all the participants. And we learned a lot, and I personally revised all my cornea in this session. So thank you so much for your valuable time, and we can have the group photo now, I think.
Mr. Sai, can you please help us with the group photo?
I'll just stop sharing for a minute.
Sure,
If
madam.
everyone can switch on your cameras, and Sai
Yes.
will help us with the group photo, please. So we can all have our YOSI symbol as well. Judges, this is our YOSI symbol. So if you could please help us out with this. Thank you.
Done, doctor.
Thank
Manjula
you.
is here. Thank you.
Yes,
Thank you,
Thank
Manjula.
you.
Thank you very
Thank
much.
you, everyone.
Thank
Thank
you
you,
so much.
judges.
Thank
Thank you for
the
having
photo
us.
on this
Thank you.
forum
Thank
maybe.
you.
Yes, on the
Yeah,
chat.
Thank you.
Thank you
Bye.
so much.
Bye.
Bye.
So Dr. Samita, if you could start slide sharing, we'll just move ahead with the quiz directly. The
Yes.
instruction have already been given to the participants.
Yeah.
Keep your chat boxes ready. Only one single device to be used for this time being, and one person to answer once you've been selected. The first person who writes in the chat box gets the chance to answer the question. If you go wrong or if you cannot answer, you will get a -2. So be careful. All right. And you all know your team numbers. The first team is
Yeah.
Eye Catchers. The second is Multifocal Warriors. Third is Eye Wizards. Fourth is the Asteroids. And fifth is Optic Nerds. So
Okay,
are
so
you
you
all
just number 1, 2, 3, 4, or 5. And what I will be doing is I will be reading out the question, and I would advise you to wait till I finish the question and put your number. Otherwise, whoever puts the number first can answer. But if you're not getting it right in 20 seconds, then you are going to get a -2. And we will be moving on to the next question. There is no pass in this round. So be very careful before putting your number in the chat box. Dr. Arshi, will you man the chat box, please? Dr. Lipi, would you moderate? Or
Yeah, I'll do the quiz.
you moderate? Sure. Okay, fine. Then me and Dr. Arshi will keep the time and the
Yes,
chat box.
absolutely. We'll be keeping the chat box responses in mind.
Fine. Okay.
All the best to all the participants.
So
So
can
this
we
is
have
just
the
a trial
quiz?
question. So
Yeah, we
guys,
have.
can you just check? So this is just a trial question. You have put it up here. Yes.
So
Dr. Lipi.
the trial question is, where is Charminar? So you guys can, type in the team numbers. You know the team numbers, right? Yes. So Dr. Arshi, you are muted, ma'am. Please unmute.
Team 4 gets to go first.
So team 4,
Hyderabad.
please unmute yourself.
Hyderabad.
Okay, can we have the answer?
Yes.
So that's exactly how you play. So now I write a XXX in the text box. The next question, the moment it comes, you start writing your team name according to the responses. All right, please move ahead.
Yes.
So let's start with the first question. So the first question is, which collagen type is the most abundant in the corneal stroma? Type 1, type 2, type 3, type 4.
Team 2.
Team 2, please unmute yourself.
Yes, ma'am. Ma'am, type 1.
Type 1. Okay, can we have the answer? Yes, so it's a correct answer.
So team 2 is multifocal warriors. Okay.
Yes,
So they get +1. Okay. So we'll move on to the next
Ma'am,
question.
wait. Can you type XXX?
Yeah, okay.
Okay, now we'll move on to the next question.
Yes, okay.
So the next question is identify the pathology depicted in the image in a child with congenital cataract, anterior lenticonus, posterior lenticonus, PSC, or pre-existing posterior capsular defect.
So team 4 gets to go first.
Posterior lenticonus.
Okay, so
No, sorry, the answer is pre-existing posterior capsular defect. So negative marking for team 4.
team 4, that is the asteroids. Okay.
Asteroid, sorry. Yeah.
So asteroid gets a -2. All right. So shall I move to the next question?
Yes.
Yes. So the third question is,
what is the most common initial symptom of optic neuritis? Sudden loss of central vision, diplopia, pain with eye movements, photophobia.
Team 3 gets to go first.
Team 3.
Pain
Eye
with
quizzers. Yeah.
pain with eye movements, ma'am.
Okay. Can we have the answer?
yes. So the answer is yes. So
it
that's
is
the correct
answer.
answer. So quizzards get a +1. Okay. So we go to the next question, question 4. Okay, so now
So
we
this
have
is
an
the
audience
aud-
question.
yeah. This is an
Yes.
audience question. So I request participants to not answer, not type in the chat box. So audience, you have to type I in the chat box. Can we have the question? Which is not a risk factor for primary open-angle glaucoma, myopia, central retinal vein occlusion, diabetes, central retinal artery occlusion.
Dr. Rashi, anybody's pressed I?
So we have Dr. Noor Nisha, who's wanting to answer the question. She's written D. Please move to the answer.
Okay.
That's the right.
No, sorry, that is the wrong answer. The answer is central retinal vein occlusion, CRVO. Moving on to the next question. This question is for our participants, for the teams.
Okay. So the question is here.
1.5 syndrome is due to lesion in parapontine reticular formation, medial longitudinal fasciculars, both PPRF and MLF, occipital lobe.
So team 2 gets to go first. Multifocal warriors.
Ma'am, BMLF.
Okay,
Can we
so
have the
let's
answer,
see
ma'am?
the answer.
Sorry, that is negative marking. That is the
Multifocal.
wrong answer. The correct answer is both PPRF and MLF.
Yeah, only MLF would cause INO and not 1.5 syndrome. Okay. So the next question here. Shall I go to the next question? Yes, here.
So the next question is the most important systemic investigation to be performed in this case is peripheral blood smear, CD4 count, CCT chest, or MON2 test.
Team 1 gets to go first.
Okay. Eye catchers.
Team 5.
Eye catcher, can you unmute yourself?
Ma'am, CD4 count.
Can we have the answer?
Yes. So that's
yes,
the
it is the
correct answer.
Ma'am,
So +1 to ICAP.
Ma'am, team 5 has written first, ma'am.
After this,
Beta, in the chat box, I've got the response from you both, but I got 1 first and then 5. 1, 5, 4, 2. That's the sequence that I've had.
We are seeing it as 5, 1, 4, 2.
Lippy, can you confirm?
No, it is 1, 5, 4, 2.
Yeah.
Beta,
So
there
I think
might
we
be
will.
a time delay at your end. That's
Yeah.
that's
So I think we'll stick to what Dr. Arshi is telling us because she's keeping tab of this. And we will quickly move ahead with the next question. Okay. So teams ready? The next question is here.
Which of the following lysosomal storage diseases commonly shows a cherry red spot? Gaucher's disease, Tay-Sachs disease, Pompey's disease, or Fabry's disease?
So team 1 gets to go first.
Eye catcher.
Tay-Sachs disease.
Can we have the
let's.
answer, please?
Yes.
Yes, it's a correct answer.
So I would also request other teams to mute, please. Only unmute when you're answering. We can hear some other conversation as well. So I'll quickly go to the next question. Okay, so next is
we have an
Anika.
audience question.
Audience question.
Okay, so shall I go to the question? Audience ready?
Yes. So which of the following is not a type of visual pigment? L, M, P, or S?
Dr.
Anybody
Rashi?
from the audience?
Not yet, but why don't any one of you make a guess if one of the audience is ready to?
Yeah,
Audience,
team
anyone?
member?
Anyone along with you who's willing to make a guess?
So if no one in the audience, then the team, anybody from teams can try. Any team would like
You
to try.
won't get extra marks for this, though.
Yeah.
Yeah.
So Prakriti gets to answer.
Ma'am, C option.
Okay, let's have the thing. Yes, very good.
So
that's
C is
the
the
correct
correct
answer.
answer, but unfortunately, you won't get any marks or no negative marks also.
But well done.
Yeah.
It's a good answer.
Moving
Except
on to
that
the
when
next
you're
question.
logged in here, you should always have your friends along, watching you on, cheering you on, also to get the audience prize for your college.
Yeah. Okay,
Moving
so
on to
the
the
next
next
question yeah, this is for the contestants, the participants.
3 days after routine trabeculectomy, a patient presents with an IOP of 1 millimeter mercury and a flat anterior chamber. The bleb is flat, the retina and choroid appear normal. What is the most likely cause of these findings? Malignant glaucoma, choroidal detachments, excessive filtration, or bleb leak?
So according to me, 2 goes first. Team multifocal warriors.
Ma'am, bleb leak. Ma'am, option D.
Yes, so you're
Okay,
making
so
up for your
let's-
negatives.
Yes. So it is the right answer. So +1 to multifocal warriors. Okay, so next we have the next question. Yeah.
All of the following are the causes of poorly dilating pupils except alpha-1 agonist, pontine hemorrhage, organophosphates, diabetes mellitus.
Team 3 gets to go first. Team 3, the question wasn't even out. You put the first 3. The second 3 came after. Don't do it again. Hanji, go.
Team 3.
Ma'am, alpha-1 agonist.
Okay, so that's the right answer.
Correct
Yes.
answer,
So +1 to team 3. So again, participants, please put your numbers after the question is out and not before that. It will not be considered again. You'll be like the next team would be called to answer. So we'll go to question 9.
So which is false regarding sodium fluorescein dye? 50% is bound to plasma protein. It is excited by 470 to 490 nanometer light and emits 520 to 530 nanometer light. It has a molecular weight of 376 daltons and it stains collagen.
Which team, Dr. Arshi?
Team 5 gets to go first. Optic nerds.
Team 5.
Ma'am, it stains collagen.
Okay, let's look at the answer. No, sorry, that's the wrong answer.
Yeah. So the correct answer is 50% is bound to plasma protein.
You use it for your corneal stain. I mean, fluorescein is what you use for corneal epithelial defects. You've forgotten that part.
So it has to stain collagen.
Yeah, the question was which is false regarding sodium fluorescein dye.
All right. Let's move to the next question.
Yeah, so we'll move to the next question. So again, I think we have one more audience question before the next question. So audience ready, please type I and answer. So this is the question.
Reduced color discrimination is most likely caused by which type of cataract? Anterior subcapsular, cortical, nuclear sclerotic, or posterior polar? Anybody from the audience? This is an easy guess.
Anyone, Dr. Arshi? Nobody yet?
Nobody yet. All the audience awards in this session are going to go to all of us. No one is willing to answer. None of your friends are here.
Anybody?
Any of the teams wants to answer?
Dr. Noor Nisha has typed.
Yes, I was waiting for Dr. Noor to say something, but she's not messaged yet. Dr. Nisha did, yeah. So Noor Nisha said C.
Okay, so let's have the answer. Oh, yes.
It's the correct answer.
You know, an interesting fact, Vincent van Gogh used to paint in different colors before he developed cataract versus when he developed cataract because his color sense changed after that. I want you to see the images of his paintings and you'll understand what I'm saying. The sunflowers that he painted and the water lilies that he painted before and after he developed cataract.
So Dr. Noor Nisha gets the prize for this audience question. Congratulations, Dr. Noor. So I think we have one more question for the participant.
Last question for the
The
quiz
last
round.
one. Yes, here it
So
is.
come on, teams. The sensory nerve most likely to be affected by an orbital fracture is lacrimal, nasociliary, infraorbital, or infratrochlear.
So which team, Dr. Arshi?
Team number 1.
Ma'am, infraorbital. Okay, let's check the
So
answer.
definitely, yeah, that's the right
Yes,
answer.
it's the
So
correct
plus
answer.
one.
Congratulations.
Excellent. So I think that brings us to the end of the quiz session.
And team
Okay,
1
so
did really well
yeah,
in the quiz, so good job.
Yeah. Dr. Samhita?
yeah, yes. Okay, yeah. So we will move quickly to the round 4 also in the interest of time. So I think we will be compiling all the marks in the end and we will be sending the winners at the end of the later. So we'll go to round 4, which is the unscramble. So for round 4, one pre-decided team member will play the round. Okay, so I want only one person to play. If you're hearing echoes and things, then it depends on how we are hearing you, because you get only 1 minute in which you have to solve as many jumbled words as possible, which is flashed on the screen. There is 1 mark for each correct answer. If you answer it wrong, you can go again, provided you have time. So whatever you do in the 1 minute is what is counted. There is no negative marking, so you can attempt as many times as you want. So we will be flashing all the words.
Dr. Samhita, I need a second. The timer app has gone away somewhere. It decided to go for Let me just switch it on again, because otherwise you'll have difficulty. The teams can just stretch for a while, because this is usually a little tough, this round that's coming
Meanwhile,
up.
I'll just show them a trial. Meanwhile, while you switch on your
Yeah, let's do
thing.
that. Absolutely.
So we'll go with, yeah, so this is the trial. So anybody can guess what could be one? So I'll just show you. So you'll get it like this. Let's not get into answering this. So you'll get jumbled words like this together on the screen in the same slide. And you can guess as many as you want, but only one person answers so that we can keep count of the marks for you. It is +1 for each correct answer. So this will be the answers. I'll be displaying all the answers at the end. Once you have attempted your 1 minute, Dr. Arshi will be keeping the time. So once she says time is up, then that's when you have to stop. And no answers after the time, please. No, I will not accept even one answer after the time. It is strictly 1 minute. Okay. So Dr. Arshi, ready? Shall we go?
Yes, please.
Yes. Okay. So first team, the eye catchers, be ready. Are you unmute? Are you there?
Yes, ma'am.
Okay. So we will begin here. Yes. Go.
Annulus.
Yes.
First is
Okay. That's
annulus
correct.
of wind.
Yes.
Third is second is ciliary zonules.
Very good. Yes. Next.
Fifth is latanoprost.
Yes. Correct.
Third is lag of.
No, that's not correct. Think again.
Travopro. No.
Yes. Yeah. Fourth one is correct. Correct. You have 2 more to go. You can attempt. 3 and 6. You don't have negative marking. Try and guess.
Yes.
Any answers? You have 2 more to go.
Fifth
3
is
and 6.
bimatoprost.
Yes, correct. Bimatoprost is correct. So only 3.
What is?
So your time is up.
Yes.
So 3
Let's go to the
was,
answers.
yeah, 3 was photocoagulation, but very well done. Eye catch. Got 5 correct. That is brilliant. That is really good. So congratulations. So next we have multifocal warriors. Are you ready?
Yes, ma'am.
Okay, so quickly your question, as soon as your question slide shows, your time will start. Yeah, here, go. You need to answer loudly.
First one is brimonidine.
Correct.
Second one is timolol maleate.
Excellent.
Third one
Okay.
is carbonic anhydrase inhibitor.
Awesome.
Fourth one is acetazolamide.
Excellent.
Fifth one is dorzolamide.
Yes,
And
very good.
sixth one is नहीं
Come on, you can do it.
Cyclosporin.
Cyclosporin.
Excellent, excellent. Very good. So you got all 6 correct. Amazing team. That's all the right answers. Brimonidine, timolol, carbonic anhydrase inhibitor, astazolamide, dorzolamide, and cyclosporine. Very well done. So you get +6. Congratulations. So next, do we have iQuizzers ready?
Yes, ma'am.
Okay, so your time starts now. Go. Yes, start answering. Any guesses?
First, Ripasudil, fourth one.
Yes, correct.
Cyclopentolate, the third
Correct. Yes, correct. Next.
one. Nitazodil.
Yes,
The
correct.
last
6th
one,
is
sixth one.
Netasudil. Yes, yes. Next.
Cyclopentolate, the third one. Oh, sorry, I've already told.
You've already told that. Yes.
Prednisolone.
Correct, correct. First is
First one.
prednisolone. So 2 and 5 to go.
नहीं. Trapinopac नहीं.
Come on, you
Time
can
is
do
up.
it. Okay, so your time is up. Let's go to the answers. You got 4 right. 2 was lotiprednol and 5 was teprotumumab. So, but very well done. You have got 4 correct and congratulations. So next we go to the asteroids. Are you ready?
Yes, ma'am.
Okay, so your time starts now. Go.
The second one is optic nerve sheath meningioma.
Excellent, correct. Next.
The fifth one is uveal melanoma.
Correct.
And the sixth one is conjunctival melanoma.
Correct. Excellent.
And
Then.
the fourth one is squamous cell carcinoma.
Excellent. Then.
And
You have 1 and 3 to go.
You need to put your video on.
1 and 3.
The third one is.
Come on. Think. 1 and 3. Time is running out. Any guesses? Any guesses?
No. This one is.
Last few seconds. 1 and 3. Okay. So I think your time is up, Dr. Harshi. Yeah. So your time is up. So we will go to the answers. So 1 was lifitigrast and 3 was medulloepithelioma. Okay. So, but still you got 4 correct. That is very good team. So congratulations. And next we have our last team, the optic nerds. Are you ready? Optic
Yes,
nerds,
ma'am.
are you there? Yeah, you need to switch on your video, please. Okay. So your time starts now. Go.
Lacrimal gland tumor.
Next. You can answer in any order, right? Guess the others. Take a guess, see the number of words, you'll know. Come on, you can attempt. Any more guesses? There's no negative. Come on, guys, you can try and guess.
Ma'am, 3 is Steven Johnson syndrome.
Correct. Excellent. That is right. Yeah, so I think your time is up. So We'll go to the answers now. So you got 2 right, but the others were adenocarcinoma, Waardenburg syndrome, Irwin-Gass syndrome, and Posner-Schlossman syndrome. So that's why I was telling you, look at the number of words. I think syndrome is common. You can see the things there. So if you have noticed, all the unscramble have a theme to it. So we've kept it that way so you could guess. But anyhow, well done. Good attempt. You've got 2 correct. So this brings us to the end of all 4 rounds team. So very well done to all the team members and all the participants. You have shown really great enthusiasm and very well done on the presentations and the seminars too. So I hope you all learned a lot today and had good fun as well. And we'll come back with other prelim session. As I said, please encourage your friends and other team members if they want to participate. We have extended our registrations till 15th March. So more teams can come in and make it more fun. And the results we'll be compiling and announcing by the end of today. You'll be getting it on the WhatsApp. We will be sending the top 2 teams, which will proceed to the further rounds. But irrespective of that, all teams are winners today. You've all done well. So congratulations to you. So we will be presenting the certificates now. We'll be sending this to you on WhatsApp as well. But just to put it out here, so we have the team eye catchers, Dr. Purvi, Dr. Raj Siddharth, and Dr. Manisha Parmar. Then we have the team multifocal warriors, Dr. Ranu Sharma, Dr. Simran Khosla, and Dr. Madhur Harsolia. And then we have the team eye quizzards, Dr. Mustafa Makda, Dr. Sanya Parak, and Dr. Mohan Prasad. The 4th team is the asteroids, Dr. Nisha Beniwal, Dr. Kanchan Sharma, and Dr. Prakriti Garg. And the 5th is the optic nerds, Dr. Samarpita Dhar, Dr. Lavina Paryani, and Dr. Sanskriti Nahar. So well done, all of you. Thank you so much. So we have the photo session now. Can all of you please, switch on your videos, and Sai can help us out with the photos. So Dr. Arshi, are you there? So everyone is here. Please switch on your videos, everyone. And the YOSI symbol once again. So this was the prelim session 5, guys. So 3 cheers. Manjula, can you help us out with the photo, please?
Sure, doctor.
Yes. So everyone smile. Thank you, ma'am, for coming. Dr. Pooja, ma'am. YOSI symbol, please, if you can. Thank you.
Done, doctor.
Yes, done. Thank you so much, all the teams. So it was wonderful having you all here. And I hope you learned something out of all this. And on a Sunday afternoon, you have shown great enthusiasm. So we really appreciate that. And so you can join our YOSI team. You can take the YOSI membership. If you are part of the final team, it is mandatory to have the YOSI membership to attend the YOSICon and register for the conference as well. Even otherwise, do come to the conference. It will be a great way to connect with everyone and be part of this wonderful society where you will get a lot of opportunities for presentations, learn from seniors, and be part of such exciting activities. So you can scan the QR code to become a lifetime member now and join our society where we do great work. So, and we also invite submissions for the International YOSICon. The last date for submission is 1st May, note, and you can send in your registrations for the free paper, videos, or case competition. So all the details will be available online. You can submit it at yosicon2025.com. Once again, I repeat, last date is 1st May. So do send in your abstracts, and we hope we get a lot of abstracts and you'll have a great time at the conference too. So this is YOSI iROCK. So may the best team win. And thank you everyone for having a great session. I thank Dr. Arshi and Dr. Lipi as well for being my co-moderators and working a lot the past few weeks to get this session done. A big thanks to Dr. Nupur, who is a team lead and who has done a wonderful job compiling everything and putting things together. And we will have prelims every week. So you can log into the other prelims as well, and it'll be at different themes. And I thank Numerotech for helping us with the videos and other things. Thank you, Manjula. You've been a lot of support to us. And I thank the entire YOSI iROCK team who have been working with all the questions, the formats and everything. And even the YOSI Governing Council, Dr. Divakant Mishra, our president, and all the other YOSI team members and members of the Executive Council who have always been supportive, and we all work as a team. So it's been a great team effort. So well done, everyone. Thank you once again. And we'll wrap up this session now. As I said, you will be receiving the winners list by the end of today. The top 2 teams will be proceeding to the further rounds. Okay, thank you, everyone. I think it was a great session.